Welcome everyone to this evening to hear experiences on high risk pregnancy. We have a galaxy of experts today. Let me first introduce the patron and the convener, Dr. Lakshmi Shrikhande. She is the medical director of Shrikhande Fertility Clinic, Nagpur, chairperson designate ICOG 2020, and she has many other accolades across association, and she's currently founder, patron, and president of the ISOPAR Vidarbha chapter. Dr. Shrikhande, the floor is yours.
Thank you so much, Session. Now, friends, I welcome you all in this webinar organized by Vidarbha Isopab on the theme of high risk pregnancy. In this webinar, we are going to have two lectures. One is on RH isoimmunization by expert Dr. Sheila Mane, and second talk will be by me on updates on anemia management. This will be followed by case-based discussion on pregnancy after 40. As you all know, you all must be receiving the elderly primaries more and more in your practice since last decade. So we have expert Dr. Chaitanya Shembekar and Dr. Rohan Palshetkar to guide you through this journey, how to manage these elderly primaries. So without wasting much time, I would like to start the scientific session. First, I would like to introduce my guest of honor, Dr. Saswati. Dr. Saswati is Professor OBGY, Guwahati Medical College. She was Chairperson Medical Education Committee of FOXI. She is currently the Vice President of National ISOPAB. She is President of ISOPAB Assam chapter, and she was past President of Guwahati OBGY Society. So welcome, Saswati. Floor is yours. We would love to have some words of wisdom from your side.
Thank you. Thank you, Dr. Lakshmi, for inviting me for this great webinar on high-risk pregnancy. And I welcome everyone. I welcome your president, yourself, and your secretary, Dr. Mukherjee. I don't think she has joined. I also welcome my other vice president, Dr. Shoshikala, Dr. Sneha, Dr. Madhumati, and Dr. Rohan is also probably there. So I welcome everyone. And I'm really happy that you have organized such an interesting session on high-risk pregnancy, but one topic at it or two topics at a time. And we know that Rh negative pregnancies, it seems we don't get cases, but recently we had a talk with Professor Deepika Deka of AIIMS, and she has done a rare case of Rh17 immunization, which is a very, very rare blood group. And for that, she has to get blood from Japan. And because there is only one same blood group in India, and that also was called isoimmunization. So, day to day, we have so many things to learn. So it's not that we know everything about Rh immunization. There are really newer things that also comes. And of course, anemia, the biggest killer of our country, and which is such a simple thing to treat, but such a complicated thing when the patient comes in the last stage. So I really thank everyone, and especially Lakshmi for doing so much of work on this webinar about the ISOPAB. And I'm really proud that ISOPAB becomes such a big, everywhere, all over the country. And maybe because of this webinar, we have been so much seen everywhere from every nook and corner of the country. So thank you so much. I wish this webinar a grand success, and thank you all.
Thank you so much, Saswati, for taking out time from your busy schedule. I know you are busy in your department till 5 p.m., 6 p.m. And so many times you were not in a position to accept my invitation, but this time I am happy that you are here on this platform. Session, please, meantime, send email link to Dr. Sheila Mane on her email ID. And I will proceed with the introduction of our guest of honor, Dr. Sasikala Kola. She is a very humble, down-to-earth person. She is currently consultant gynecologist and obstetricians at Rainbow Hospital, Banjara Hills, Hyderabad. And she has done step ladder work in her state chapter, that is ISOPAB Hyderabad chapter. And currently she is president of ISOPAB Hyderabad chapter, and she is vice president of National ISOPAB. And her field of interest endoscopic surgery, vaginal surgery, and high risk obstetrics. And she has been trained in robotic surgery at Atlanta way back in 2011. So, Dr. Sasikala, the floor is all yours.
Madam, you're muted.
Yeah, thank you, Dr. Lakshmi, for this introduction. And as I was mentioning earlier, this is the fact that we have been invited as a guest of honor means we are growing old, but that doesn't mean nonetheless we need to be updated. And I am very happy that these webinars that you are all organizing, the ISOPAP all over India is organizing, is really keeping up all the members updated and in touch. Actually, earlier we were not seeing meeting each other so often, but now with these webinars we seem to be seeing each other more often, which is a welcome change. And I wish your this webinar all success, and that panel discussion is one thing which I think is very, very important, because we are seeing more and more women coming to us later and later in their lives in pregnancy, and they have their special problems which I think needs to be highlighted, and we need to update ourselves in that aspect also. I wish this webinar all success, and thank you for inviting me to be a guest of honor for this session.
Thank you so much, Dr. Sasikala. I know you are young at heart, but you are senior. I was telling you that you are senior in the national organization. So that is
And I
why
am
you are
past president.
guest of honor.
I am a past president of Hyderabad chapter. The present president is Madhumati. Dr. Madhumati
Okay,
is the
okay. So
present
I'm so
president.
happy to have you both past and present presidents of Hyderabad ISOPA. And thank you so much, Dr. Sasikala. And for these elderly primies, we IVF practitioners are not solely responsible, as many of these women, they delay the childbearing on their own. And I'm sure Chaitanya and Rohan will elaborate on that. I would like to recognize the presence of Dr. Milind Shah, who is our patron of Vidarbha ISOPAP chapter. Today, he has sent his apology. He is busy somewhere, and he was president of National ISOPAP in 2016-18, and currently he is Deputy Secretary General of Asia Oceania Federation of Perinatal Societies. And as you can see, his list of achievements are many. He has received many awards, and he has got many publications to his credit. So welcome, Milind. Next, I would like to acknowledge the presence of our founder president, who has given birth to the Vidarbha ISOPAP chapter, that is none other than Dr. Sneha Bhuyar. Sneha, welcome on this forum. And currently she is chairperson of study of female breast disease committee of FOXI, and she is elected as governing council member of ICOG. Again, her list of achievements are too many, Sneha. So please excuse me if I don't read out your biodata, but I would like to have some words from your side in the capacity of founder president. Sneha?
Yeah, thank you so much, Lakshmi. At the outset, I would like to congratulate Vidarbha ISOPAP and yourself specially, personally, for this wonderful activities, series of webinars on a variety of topics. Of course, the range of faculties I can see, ISOPA, FOXI, ICOG, and across India, all over rather, I would say. So juniors, seniors, and of course, I welcome all the faculties across India, all the past and present presidents of ISOPA Hyderabad. I can see Dr. Sheila Mane, all the faculties today, Dr. Varsha Dhore, Saili, all of you, Dr. Saswati, Dr. Shashikala, everybody I welcome. And I just say very important subjects, fetal outcome in Rh negative pregnancy, anemia, the current, I won't say current, the burning topic, as always for India, I think it will be there for ages. And of course, the very interesting, much awaited panel discussion on the elderly gravida. The floor is all yours. Once again, I welcome you all and thank you so much.
Thank you so much, Sneha. for your presence and your words of wisdom. I would also like to acknowledge the dynamic ISOPAP secretary, Dr. Alka Mukherjee, and she has taken over as president of Nagpur OBGY Society. She is having some emergency. She will be joining us shortly. So now we will go ahead with the first session. Dr. Mala has not joined yet, na? Okay. So I would like to introduce the chairpersons of the first session, Dr. Madhumati and Dr. Saili. Session. Hello. Dr. Madhumati is Senior Consultant, OBGY Apollo Hospital, Hyderabad, and her area of interest is high-risk pregnancy and adolescent gynecology. Welcome, Dr. Madhumati. Dr. Saili. She is currently the Assistant Professor of OBGY at Punjab Rao Deshmukh Memorial Medical College, Amravati, and she is affiliated to FOXI, IMA, ISOPAP, and she has held various positions in the organizations. She has got various awards and she is a great academician. So welcome, Saili. I hand over the floor to you for further proceedings. To the chairpersons.
Thank you, Dr. Lakshmi. I know that Dr. Lakshmi is such an active member in ISOPAB, and with all the webinars that she has been organizing, that she doesn't need any introduction, but still it gives me pleasure to introduce her to the audience. Dr. Lakshmi Srikhande is the Medical Director, Srikhande Fertility Clinic, Nagpur, Chairperson Designate ICOG 2020, National Corresponding Editor, Journal of OBGYN of India, National Corresponding Secretary, AMWI, Senior Vice President, FOXI. The list is just endless. What we do know is that she's the dynamic president now of the Vidarbha's ISOPAP Society chapter, and we all have been seeing how dynamically she has been with her team, been conducting some amazing webinars in the last few months, and kudos to you and your team, Dr. Lakshmi. She's going to be speaking to us on an update of anemia in pregnancy. We all know that anemia is one of the most prevalent health problems that exist in the world, and more than about 500 million women in the reproductive age group are affected with anemia. And today we're all ears to listen to what Dr. Lakshmi has to say to us, the latest developments in both diagnosing and latest management protocols that are available for treatment of anemia in pregnancy. Over to you, Dr. Lakshmi.
Thank you so much, Dr. Madhumati, for such kind introduction. Friends, I am sticking to the management, as the diagnosis in itself is a very, very broad topic and it takes a lot of time. So let me update you on the management of iron deficiency anemia. Session, you will have to be very alert and please go on clicking the slides. We all know the burden of anemia in India. It is 60% in the urban population and 69% in the rural population. And as anemia is the late indicator of iron deficiency, so the prevalence of iron deficiency is 2.5 times more than that of anemia. Next. And this is just the tip of iceberg effect. Next. Anemia still remains a major killer disease in India. 1/5 of the maternal death in India is directly related to anemia. Next. Anemia can be physiological in pregnancy, and pathological anemia can be nutritional, can be hemorrhagic, and can be a hemolytic anemia. Next. But I will be focusing on the iron deficiency anemia, which is the commonest anemia. Next. सेशन आप थोड़ा सा नेक्स्ट बोलने के पहले स्लाइड आगे लेके जा सकते हो. Iron deficiency anemia is the most common nutritional deficiency in pregnancy, and as we all know that these ladies, they have physiological anemia because pregnancy is a state of negative iron balance. There are various maternal complications of anemia in the antepartum phase, in the intrapartum period, and in the postpartum period. Antepartum, it can lead to preeclampsia, APH, abruptio, infections, PPROM, preterm labor, cardiac failure. Intrapartum, it can contribute to prolonged labor, PPH, labor dystocia, increased incidence of operative deliveries and cardiac failure. And in the postpartum period, it can contribute to puerperal sepsis, subinvolution of uterus, failure of lactation, thromboembolism, and delayed wound healing. Next. In the fetus also, this anemia can give rise to many problems. The perinatal complications can be in the form of IUGR, low birth weight, neonatal anemia, neonatal infections in preterm birth, and long-term sequelae of this anemia during pregnancy can be delayed cognitive function in the child. So we know that anemia has got such serious consequences for both mother and the baby. So who should be screened for anemia during pregnancy? Our guidelines tells us that all pregnant women should be screened for anemia during pregnancy irrespective of their gestational age at first contact and the socio-economic status. How often it should be repeated? Because just one hemoglobin detection is not enough. You have to do minimum 4 estimations at 14 to 16 weeks, 20 to 24 weeks, 26 to 36 weeks, 26 to 30 weeks, and 30 to 34 weeks. Next. ICMR has graded anemia into mild, moderate, severe, and very severe. Mild is between 10 to 10.9. Moderate is 7 to 9.9. Severe is when it is less than 7, and very severe when it is less than 4. So let us come to the treatment of iron deficiency anemia. You have to strike the iron when it is hot. So the first initiation of therapy is, of course, the medical nutrition therapy, deworming. Then you have to decide whether your patient falls into the category where you can start oral iron or you have to give parenteral iron. You have to assess the response, and we will discuss the indications for blood transfusion. So when you are initiating therapy, it has to be started with the aim to correct the iron deficiency, to restore the iron reserve, and to correct the, please mute everyone, to correct the associated complicating factors. And with this aim, your choice of therapy depends on severity of anemia, duration of anemia, and the presence of associated complicating factors. So what is the basic advice which you will give to your patient on medical nutrition therapy to improve her iron intake? You have to tell her that consumption of iron-rich food she has to include in her day-to-day life, and these iron-rich foods are jaggery, spinach, pulses, eggs, liver, fish, cereal. She has to cook food in iron utensils. Intake of heme iron has to be increased. She has to add the ascorbic acid, that is vitamin C. It increases the absorption of iron. She has to avoid the phytates, coffee, tea intake with the iron supplements, and she should take iron supplement between meals rather than taking with meals. So iron rich foods I have already emphasized. Next. Next. In government programs, all the health facility based programs where food is being provided, like in schools, in the settings where ASHA workers are providing nutrition to the antenatal mothers, it is mandatory to provide the fortified wheat and rice with iron, folic acid, and vitamin B12, and double fortified salt. Not only iodine fortified, but the salt should be fortified with iron as well, and the oil which is fortified with vitamin A and D. Deworming, the main target of Anemia Mukt Bharat 2018 is to give tablet albendazole 400 milligrams stat to all antenatal patients after the first trimester, preferably in second trimester. The WHO 2007 recommends that where the hookworm prevalence is more than 20% or more, you can give one of the following anthelmintic agents, like you can give tablet albendazole 400 milligrams stat, or you can give mebendazole 500 milligram stat or 100 milligram BD for 3 days. Next. But if the hookworm is highly endemic, that is prevalence is more than 50%, you have to repeat the dose after 12 weeks of your first dose. So now let us see oral iron versus parenteral iron therapy. The advantages of oral iron therapy is that it is cheap, easy to administer, there is no hypersensitivity reaction. But the disadvantages are in the form of gastrointestinal intolerance, it is poorly absorbed, variable absorption rates, and difficulty in replenishing stores. Whenever you are prescribing oral iron, you have to give general instructions to the mother that she has to take it between meals. She has to avoid simultaneous consumption of tea, coffee, milk, or calcium tablets. So don't give a combination of iron and calcium tablets. Start with the low dose of iron to decrease the side effects. Change brands if she feels that she is not tolerating this brand of iron, and you can use the iron solutions as well. The government of India has recommended in 2018 that if you are giving oral iron for the prophylaxis, then you have to give elemental iron in the dose of 60 milligram daily plus folic acid 500 microgram daily till term, and you have to give this combination for a minimum of 180 days. Mild to moderate anemia, you have to treat, and for treatment, 2 tablets of iron are recommended. If it is severe anemia, you have to give parenteral iron, and if it is very severe anemia, you have to give blood transfusion. In the postpartum period, your treatment regimen is same as for prophylaxis during pregnancy. So which iron to give? We have got many salts which are available in the market, but WHO recommends ferrous form, and it is preferred over the ferric form because of good bioavailability. It has acceptable tolerability, and it has got high effectiveness. The iron salts are inorganic, organic, elemental, and chelated iron which are available in the market. So let us see the common preparations which are there, how much iron they have, and what is the percentage of elemental iron. The ferrous sulfate in a 200 milligram tablet has 32% of elemental iron, and the maximum elemental iron, as you can see in this chart, is in the carbonyl iron. That is a 100 milligram tablet has got 98% of elemental iron. Ferrous fumarate, ferrous sulfate, and ferrous glycinate are the cheapest and the most commonly used forms. Ferrous ascorbate, it has got antioxidant effect, it protects the GI mucosa, it has got high bioavailability, and it is most suitable for Indian diet. Carbonyl iron has got microparticles of purified elemental iron, it is not a salt, it has got low toxicity, lesser GI side effects, absorption rate is slow, and it permits continued release for 1 to 2 days. Ferrous bisglycinate has amino acid chelate. Absorption is not decreased by phytates. High bioavailability is there, but it is costly. Ferric ammonium citrate is mostly commonly used ferric salt. It requires conversion to ferrous salt in stomach, and it has got less bioavailability. Ferric hydroxide polymaltose complex, the GI irritation is less, but it is costly, and generally it has got a poor bioavailability. So costly is not always a good iron salt. Whenever you are prescribing, you have to remember that. Next. Now we always have this query, can oral iron be given in the first trimester? Practice, in our day-to-day practice, we try to avoid because of severe gastric irritation, but practically it can be given if it is indicated, as it is used in first trimester is endorsed by most of the guidelines. The side effects we all are very well aware of: constipation, in some patients diarrhea, epigastric pain, heartburn, black color stools, nausea, vomiting, metallic taste in the mouth, and staining of the teeth. So you have started the oral iron. So how you will assess whether your patient is taking the oral iron properly or not, first thing, and how her hemoglobin levels are increasing or not. So the increase in reticulocyte count is the earliest marker of response as early as 3 days. After 3 days, you can see and document the increase in reticulocyte count. You should be able to document 1 gram of hemoglobin rise in 2 weeks and 2 gram hemoglobin rise in 4 weeks. Of course, this has to be in the absence of other micronutrient deficiencies and the ongoing blood loss. So what to do if she is having a suboptimal rise? You have to check the compliance, whether she is taking your iron regularly or not. You have to reconfirm the diagnosis that this is truly a iron deficiency anemia. And if even if with your correct diagnosis, with her proper compliance, her hemoglobin rise is not documented, you have to consider shifting to the parenteral iron. Parenteral iron has got many advantages, that the bioavailability is complete. It has got very few GI side effects. There is a faster recovery of hemoglobin, but there are some side effects as well. There is an increased risk of oxidant damage, increased cost, small but definite risk of hypersensitivity reaction is there with parenteral iron. We have many parenteral iron preparations, first generation and second generation. First generation, we all have practically stopped using in our day-to-day practice. Second generation is ferrous gluconate and iron sucrose, which has to be administered in low doses because of the labile iron complexes. There is more chances of free iron release and subsequent toxicity if it is given in higher than recommended doses. The third generation parenteral iron preparations are ferric carboxymaltose, iron isomaltoside, and ferrumoxitol. It is a unique, strong, complex structure, releases much lower levels of labile or free iron, and it allows the large doses of iron to be given over a shorter time period. But before you can think of or starting parenteral iron therapy, there are certain prerequisites which you have to fulfill. You have to confirm your diagnosis that it is iron deficiency anemia. You have to give adequate supervision for management of anaphylactic reaction. Stop oral iron at least 24 hours prior to your parenteral therapy to avoid toxic reactions. Sensitivity test is recommended. It is not recommended for iron sucrose and FCM. And you have to watch for reaction in the form of chest pain, rigors, hypotension, dyspnea. And whenever you are giving IV iron, your emergency tray should be ready in the event of adverse anaphylactic reaction to your patient. The dose calculation is very easy. It is available everywhere, this formula. But when you are calculating the dose, the target hemoglobin should be taken as 14 gram %. Intramuscular iron has been advised by the Ministry of Health and Family Welfare, but we all have stopped because of the inconvenience of painful injection, dark discoloration of the skin, and the risk of myalgias, arthritis, and hypersensitivity. So let us come to the commonly used parenteral iron by all of us. Whenever you are giving iron sucrose, it is available in 5 ml vial. It with 20 milligram of elemental iron. It should be administered as a slow infusion of 200 milligram per dose in 100 ml of 0.9% saline should be given over a period of 20 to 30 minutes. During first 5 minutes, you have to give infusion at 20 to 30 drops per minute, and then you can increase the rate to 80 to 90 drops per minute. Subsequent dose can be given for over a period of 20 to 25 minutes, and too slow or too fast rates have been associated with side effects. So remember, half an hour is a good enough time where your IV saline 100 ml should be over. The common preparations available in the market are iron sucrose and ferric carboxymaltose. We all are daily using the iron sucrose, but you all can use the FCM as well. Next. When to assess the response when you are giving the parenteral iron? The response in the symptoms is immediate. Patient can tell you that there is an improved mood irritability within 24 hours. Her appetite has improved. There is an increase in reticulocyte count after 7 to 10 days. Rise in the hemoglobin after 2 weeks is 1 gram per week, and hemoglobin level reaches to normal levels by 6 to 8 weeks. If there is no significant improvement in 3 weeks, diagnostic re-evaluation should be considered. When to give blood transfusion? If she is less than 36 weeks and her hemoglobin is less than 5%, or if she is more than 36 weeks and her hemoglobin is less than 6 gram, this is an indication for blood transfusion. Other indications for blood transfusion in pregnancy are in the presence of acute hemorrhage with hemoglobin less than 6, when anemia is not due to hematinic deficiency, and when patient is in labor with severe anemia. Whenever you are giving blood transfusion, you have to take an informed written consent. Always explain that there are certain risks of blood transfusion. You have to explain to the patient that this carries a small risk of an adverse effect, common manifestations in the form of fever, chills, urticaria. But in the rare event, blood transfusion can also have some life-threatening reactions, which you have to recognize, respond, and report the adverse event to the blood bank from where the blood has been issued. Next. Don't forget the postpartum anemia. The cutoff value for anemia 1 week postpartum should be identical to the cutoff value for anemia at delivery, that is 11 gram%, and anemia at 8 weeks postpartum should be defined by a hemoglobin concentration of less than 12 grams. So this is the cutoff for the puerperium patients, and the treatment of postpartum anemia is same as that of antepartum period. For mild symptomatic woman, you have to give oral iron in the dose of 100 to 200 milligram. For moderate anemia, it has to be IV iron. And for severe anemia or evidence of hemodynamic compromised patient, you have to give blood transfusion. Wherever possible, a follow-up CBC with serum ferritin should be considered before discontinuation of iron therapy at 3 to 6 months. So friends, this is the final slide. The take-home message is prevention is better than cure. I know we are infertility specialists, so we do see almost all the patients in the preconception period. But nowadays, this young generation has become very tech-savvy, very aware. They have started coming to the obstetrician for preconception counseling. So it is our duty to detect the anemia during the preconception period wherever it is feasible and possible. If detected, it has to be treated. If she has become pregnant and she has to come to us for first antenatal visit, irrespective of the duration of pregnancy, her anemia detection test should be done. 4 repeat tests are mandatory, but it should be repeated as and when you feel that it needs to be repeated. You have to repeat. Deworming, nowadays new guideline is that it has to be given to each and every pregnant woman in the 2nd trimester. Whenever you are starting treatment for the mild anemia, it has to be with the oral iron. For moderate to severe, it is parenteral iron. And for very severe anemia, it is the blood transfusion. So it all depends. You have to individualize the treatment and decide and manage the anemia so that we can reduce the maternal mortality, morbidity, and also the perinatal mortality and morbidity. Thank you so much for your patient hearing. Thank you so much. You can stop screen sharing here.
Thank you, ma'am. That was a very wonderful talk, very wonderful, precise and concise talk. Dr. Srikhande ma'am has nicely explained the various forms of iron, doses of iron, and how to give them. Anemia is a very common prevalence, and there are hundreds and hundreds of preparations of oral and IV iron. So it is very difficult to choose one form of iron over the other. And madam has very nicely explained which form of iron to use, the doses to use, in which patient it should be used. So it was a very wonderful talk. Thank you, ma'am.
Yeah, I would like to acknowledge the slide contribution by Safe Motherhood Committee Chairperson, Dr. Preeti. So thank you, Preeti, for the slides.
in our hospital, what we do, for postpartum anemia, because once they go home, even if you prescribe iron tablets, they don't take, they don't take, most of the people. So what we do, because we have a hospital supply of iron sucrose and even some ferric carbon, so they may go to 500 milligrams stat if you get FCM, or if we get this 203 doses, and then we set them off. At least we give them that dose, that even if they are not taking, this is very, very difficult. This is very bad because we have a hospital supply. That is why it's possible.
Saraswati, I understand because you are getting hospital supply, but that slight risk of hypersensitivity and anaphylactic reaction is always there. So you are giving in good faith, but if patient develops, no, Sheila is saying yes, we can give.
No, we have not seen so far anaphylactic.
In hospital we give under proper guidance.
Iron sucrose you can give. Iron sucrose you can give.
No, FCM also, iron sucrose also.
Everything.
Everything. Yeah. And one more point, the postpartum anemia, there is an inflammation in the bowel. And even if we give oral, it is not well absorbed. So it is what Dr. Shashwati says, and you also said postpartum anemia, it's better to give them an IV iron shot and send them, because they won't be taking tablets for some time, at least after going home. And most of them are anemic. So it will be, I think, go a long way in correction of anemia as well as giving them a better health.
Yeah, postpartum, that constipation, that fissure, a lot of people, they don't like to take oral iron, that is.
Even I agree. I agree that parenteral iron is the better route to give postpartum, because they also have sleepless nights, hyperacidity, they don't tolerate iron, and they are so busy with the child, they may skip many medications. So, correct.
Hi, everyone.
Hi.
Hi. May I add something?
Yeah, Seema, you are most welcome.
Yes, I just wanted to say FCM is the safest ever iron available for parental route. Right now, I have just infused 4 patients. They are just waiting in OPD, my IVF pregnancies. After 6-7 months, there's so many medicines. They are not able to tolerate iron at all. And I continually give them parental, and touch wood, so far no reaction and very good hemoglobin coverage. I just wanted to add that.
Dr. Lakshmi, I think there are a couple of questions from the audience for you.
Yeah, you can,
We'll take them now. So this is from Dr. Ranjana Jha, who's asking how to treat mild and moderate anemia in first trimester.
If it is indicated, all the guidelines says that you can give the oral iron, but it is not tolerated because of the GI side effects. So I think Sheila is here. They will say parenteral.
No, parenteral usually we don't give in first trimester.
First trimester.
No, it's not indicated.
Oral iron.
And it's mild and moderate anemia only. So I think starts with oral
we
iron.
don't have to worry actually. After 12 weeks, we can as well give her IV iron and improve her anemia. And already if she has hyperemesis or morning sickness, oral iron will again cause more problems. So
wait till
we can wait till 12 weeks and then give her either oral or IV iron.
But first trimester, everybody don't get nausea, vomiting. So the people who are not having that problem, I think you can
be given oral iron, yes.
Yes.
Sasikala, you are muted. Unmute karo.
The amount of iron that is absorbed by anemic patients is much higher. So if they are able to tolerate it, there is enough time to give oral iron. Only if they don't tolerate, then we go to parenteral. That's what we follow anyway.
Yeah, because its time is more, so you have enough time, so oral iron is better, definitely.
I think there are no more questions. So if you want to move on to Dr. Sheila. There's one more question which just came up. Dr. Aishwarya from Nagpur. How many IV iron sucrose can be given maximum in 1 week?
I give 600 if you are giving iron sucrose, and you can give in one shot 1000 if you're giving FCM.
Yes.
And you can repeat in the next week. I think that's what we follow here in medical college.
I think alternate day. So in a week, 3 dosages, right, Shashwati? 200, 200, 200.
People don't want to stay in medical college for 6 days, So here we are even giving 200 daily, 3 days. Initially, we used to give on alternate day, but nowadays we're giving it daily because they don't want to stay. You can't ask the patient for this iron injection, you have to stay.
I know,
So
I know. You can't keep them.
500 can be given. So it is, but not more than 600 or
Not
if
more
it is
than
iron
600.
supers, but 1000 it is AFCL.
So thank you so much all the experts for giving your expert comments on anemia in pregnancy. Now let us move to the second session, and I would like to introduce the chairpersons of the second session. And it's a pleasure to introduce my dear friend Dr. Varsha Dhawde. She is in the state supervisory board member of PCPNDT, and she's a government nominee in this board. She is president elect of our Nagpur society, and she has been the honorary secretary and the past VP of NOGS. She was the past VP of IMA Maharashtra State, and friend, she was the past president of our IMA Nagpur. She has won many awards, and she's a great academician, orator, and a great friend. So welcome Varsha on this webinar. The chairperson is Dr. Mala Srivastav. She is senior consultant and professor at Sir Gangaram Hospital, New Delhi. She is president of AOGD. Currently, she is the zonal chairperson of National ISOPAB. She is secretary of ISOPAB Delhi chapter, and she is national corresponding editor with me for Jogi. And she has held various posts in so many organizations, and she is a thorough academician. She has got many publications to her credit. I welcome you, Dr. Mala, and I hand over the floor to the chairpersons for further proceedings.
Thank you. I hope I am audible. Okay. At the outset, thank you team ISOPAB, Dr. Lakshmi and Dr. Alka for giving me this honor. Our next session is an equally important and interesting topic of fetal outcome in Rh negative patient. And for this, we have with us a very versatile and competent personality, Dr. Sheila Mane ma'am. She is an erudite speaker, and of course, commonly she is called as the PPH lady, and she will definitely do justice to this topic. Just browsing her CV, I would like to tell a few points about her. Sheila ma'am, we are very close to her because she belongs to Nagpur. You know, she has her roots here. So that's why we are instantly attached to ma'am. At present, she is a DNB professor at KC General Hospital, Bengaluru, senior consultant at Anugrah Nursing Home. Madam has done a wonderful job as an organizing secretary of AICOG in 2003 and 19. She was the vice president of FOXI in 2014, chairperson of Safe Motherhood Committee, and a national coordinator of PPH workshops, to name a few. She's got many prizes and awards: the Best Committee Report Presentation on Safe Motherhood, Best Society Award, then the President's Trophy, DK Trunk Trophy, and she is a lead accessor for Manyata. She has conducted over more than 100 PPH workshops, and that's how we know her, and she's called as the PPH lady. She's conducted the South Zone UFOXI, the Mother and Fetus, the Emergency Obstetrics, the IMS, the National ISOPAB, and so many more. So I present to you here the PPH lady, Dr. Sheila Mane, to talk on a very important topic. Ma'am, the floor is all yours and you can go ahead.
Thank you, Varsha. Just give me 1 minute. My internet connection is becoming unstable. I will just connect the hotspot, okay? And then I will connect my PPT. Just give me 1 minute, okay?
Till that time, we can just have a word on anemia. Hello.
Yeah, of late we are seeing lot of.
Yeah, just a minute, just 1 minute.
Yeah, ma'am, you take your own time. I was just saying that what Madam was saying, Shashikala ma'am and Saraswati ma'am, that even that is what we are practicing here in private hospitals also. Once the patient delivers, you go in for a hemoglobin, what is the count, the CBC, and then if she needs that, she is in the hospital for 2 to 3 days post-op. So we can immediately give her the doses and send her. So that is again one of the good practices where we can, patient shouldn't be taking oral iron immediately because she has a lot of antibiotic and many more medicines to be taken. So this is what theme which is regularly followed by us in the private practice.
And I've also found women with B12 deficiency, even if we supplement them with iron,
yeah,
vegetarians, if they're vegetarians, giving them B12 injections also quickly improves their hemoglobin.
Right. And ma'am, in Maharashtra, we have more of sickling here. We get sickle patients, the trait and the disease. So then there also is a big deficiency, folic acid. Yeah.
That is a routine practice we are doing on admission. First visit, we are doing the HPLC, the test.
Yes.
Yes, that is necessary. That is
very necessary. Yes.
Very necessary. There are a lot of things you have to do. Yeah, okay.
Yeah.
Sheila,
Can I?
You're there.
Yeah. Thank you. Thank you, Dr. Varsha, for those kind words. And whenever I virtually visit Nagpur, I have so many fond memories because I am a Nagpur product. So thank you very much for those kind words. And now I would like to share my presentation. Is it visible now?
Yes.
Yeah, thank you.
Yes.
Yeah. So fetal outcome in RH negative pregnancy. The technical team, can you just guide me how to remove this screen I am getting with the photographs which is obstructing my station?
Yes, ma'am. There is a minimize option over there.
On the top.
Yeah, on the top.
Yes, ma'am, on the top.
On the top. There is a one line that you can put it there. It will just a line will come.
Or else you can drag and drop anywhere on your screen. It is totally movable, ma'am.
I am getting 3 lines there, 3 dots.
Then you have one line also.
Yes, ma'am. You just need to click on the.
On that 3 dot, can I?
Dr. Sheila, if you look towards the top, you have view options. If you just click on that, there is an option called as side by side. I think that should solve your problem.
I'll just see. I'm not getting that view options. I'm not getting.
Ma'am, you can.
You can just minimize it. Just put it on the single.
Priyanka, can you just remove this and help me? You just help me to remove the screen from here. Yeah. This minimize. Yeah. Okay. Fine. Thank you. So now let us learn about the genetics of the RH system. Now the RH antigen is located on the short arm of chromosome 1. And there are 6 genes responsible for the production of RH antigens. And these are 3 on each chromosome, designated C or capital C, D or capital D, E or capital E. Now the blood production in the fetus begins at about 3 weeks. And RH antigen on the RBCs is found as early as 38 days after conception and required only 0.03 ml of blood to make the mother sensitized. So that I think we have to really look at it because it takes only 0.03 ml of blood for the mother to get sensitized. Now, isoimmunization, what happens? After birth and in utero, hemolysis. Now, if it is after birth, we know commonly we have seen anemia, jaundice, kernicterus, hepatic failure, which can lead to death. In utero, there will be anemia, increase in the level of bilirubin, okay, and but maternal liver will have no effect. Anemia, there is an increased hepatic erythropoiesis and dysfunction, the fetal liver. There is portal and umbilical hypertension, which causes heart failure. which leads to erythroblastosis fetalis and can lead to intrauterine death. So the birth of an affected infant, there are wide spectrum of presentations. Rapid deterioration of the infant after birth may continue. I'm in a webinar. I'll call you back. Sorry. And may continue for few days to few months. So there are chances of delayed anemia at 6 to 8 weeks, probably due to persistence of anti-RH antibodies. Now, the risk of isoimmunization, the risk of postpartum isoimmunization increases with the amount of feto-maternal hemorrhage. There is a secondary immune response and can be stimulated by as little as 0.05 ml of Rh positive cells. The risk is about 16% for the first Rh plus ABO compatible pregnancy, and the risk is 2 to 3% in an ABO incompatible pregnancy due to rapid clearance of fetal cells by destruction with maternal anti-A or anti-B antibodies. That means we can also see ABO incompatibility. So now this is the picture where we can see that how it works, First, there are IgM antibodies, okay? And these antibodies will enter through the placenta, can cause fetal anemia. Later on, there is a secondary response. There are T helper cells which come into picture, the beta cells. There are IgG antibodies which are formed, and these antibodies again enter through the placenta and cause fetal anemia. And then we will find that IgG antibodies are there. Now, there is destruction of the fetal cells by the fetal reticuloendothelial system because there are antibodies, and that causes fetal anemia. That causes fetal anemia, fetal hypoxia, and stimulation of erythropoietin. There is extramedullary red cell synthesis, hepatosplenomegaly. So sorry, I am using this this one, because of the phone hotspot, all these problems. I'm really sorry. Hepatic cell failure, hypoproteinemia, increased intrahepatic pressure, portal hypertension can lead to ascites, edema, hypoxia, placental thickness, polyhydramnias, and pericardial effusion. Now, this feto-maternal hemorrhage leads to sensitization of RHD negative mothers, resulting in an increased risk of hemolytic disease of the newborn, and such events causing FMH are causing sensitizing events. Now, there are certain procedures during pregnancy which like amniocentesis, umbilical cord sampling, chorionic villi sampling, external cephalic version, and clinical complications like threatened abortion, abruptio placenta, placenta previa, MTP, intrauterine fetal death, vesicular mole, and miscarriages. So we have to take all these things into consideration. Now, the feto-maternal hemorrhage leading to Rh isoimmunization, what is the incidence? About 6 to 7% in first trimester, 13.9% in second trimester, 29% in third trimester. So as the trimester advances, it is more. And the amount needed for sensitization is 0.1 ml of feto-maternal hemorrhage can cause 1% sensitization, 0.5 ml to 1 ml causes 25%, and more than 5 feto-maternal hemorrhage per ml can cause 65% of sensitization. Now, what is the disease burden globally? If we look at that, in 2010, the babies affected worldwide were 373. Global prevalence of RH disease is almost 276 per 1 lakh live birth, and 80% of babies of RH disease and extreme hyperbilirubinemia occurred were born in countries with neonatal mortality rate of more than 15. And neonatal death due to RH disease is 24%, kernicterus 50%, and 7.2% of all RH disease affected who survived developed kernicterus. That means we have to look at this, that we have a SDG goal now. We know that one of the cause for that is contributed by RH isoimmunization. We have to really look at it. So this is the graph again which shows that high income countries then East Asia and Europe and everywhere, what is the burden? Yes, South Asia, it is definitely the neonatal death rate due to Rh disease is quite high.
Dr. Sheila, there seems to be a small cut in your presentation since the
I know. I am not able to do anything for that now, but I think everybody is able to look at it.
May I request you to kindly stop share and share it again, so that I think that should rectify the problem.
You want me to do that?
Please, madam.
Okay. I'll share it again.
Yes, ma'am.
I'm really sorry for this.
Madam, please press the enable editing button and then go to the full screen.
On my laptop?
There is an orange or yellow band which says enable editing on the top.
Sorry, please guide me.
Madam, over above the first slide, you can see a pop-up which says enable editing.
Sorry. Slideshow, resume slideshow.
No, there is an orange band on the top. Underneath it is an yellow band, small yellow band. On the right hand side on yellow band, you will see that enable editing. Can you see it on white, in a white square?
Slideshow, it is showing resume slideshow.
No, come down a little bit, orange band, come to that light pale yellow band stripe. Yeah, come down.
Reflected view दिखाए नीचे और नीचे
आ जाइए
और नीचे और नीचे आओ और नीचे आओ
right.
Now we go to the right और नीचे आओ come down. Yes, now go right. Now right, enable editing
on the right side.
Ma'am, can you accept my request? So I will.
Yeah, you only please share my presentation. Otherwise, I'm not able to do. Sorry, I'm not so tech savvy. So
there, just above. Go there.
वही तो enable editing है.
हाँ, नीचे आना. शीला माने आपका नाम है ना? हाँ, that.
Exactly.
Yes.
कर दिया. Yeah, now I can do the slideshow.
Yes.
Yes, madam.
Sorry.
Now we can see the full slide.
Yes, now we can see. Go to the slide where you have left.
Yeah, this is the one. Yeah.
No,
so the prevalence of Rh negative population in India, if we look at this, I think it is just around 5 to 10% overall in India. The states where it is more is Himachal Pradesh, then Kashmir, Uttaranchal, and otherwise it is between 5 to 10% overall amongst the other states in India. Now coming to the screening and diagnosis. Yes, maternal blood grouping, Rh typing and antibody screening at their first prenatal visit is must, and presence of anti-D antibodies in serum is diagnostic of maternal Rh isoimmunization. The gold standard tests are indirect Coombs tests to detect the isoimmunization before delivery. So how it is done? They mix the Rhd positive cells with maternal serum. The anti-Rh, anti-D antibodies will adhere. Then the RBCs are washed and suspended in Coombs serum, which is anti-human globulin, and the RBCs are coated with antibodies will be agglutinated. The direct Coombs test, usually we advise it after the birth, and mainly it is done on the fetal blood, where we mix the infant's RBCs with the Coombs serum, and maternal antibodies are present if the cells agglutinate. So the indirect Coombs test, administration of anti-D in antenatal period to prevent isoimmunization. Now, as such, if we look at the guidelines in India, we still don't have guidelines. Even the GCPR also do not advocate antenatal, but we know that there are guidelines abroad where antenatal is advocated. Now, indirect Coombs test is done to check whether the mother is sensitized or not. Okay. I will not go into the details that how it is done. And if the agglutination is present and the ICT is positive, that means that the mother is sensitized. Okay. And if the mother is sensitized only, we think of giving an antenatal prophylaxis, but sorry, not sensitized. If she is sensitized, then we don't have to give any antenatal prophylaxis. Now, how do we screen and diagnose? Ultrasound for detection of hydrospitalis. If we have really suspect, I mean, if the mother is sensitized and we know that there are already chances of fetal anemia, we may have to do chorionic villi sampling to know the fetal Rh genotype. Amniocentesis to detect the amniotic fluid bilirubin, which is invasive. Chordocentesis to detect fetal anemia, which is again invasive. What is most important is now we have moved again for monitoring these patients is middle cerebral artery peak systolic velocity by color Doppler, which is a non-invasive method, but it helps us to determine the severity of fetal anemia. So the aim of management during pregnancy is to predict which pregnancy is at risk, to predict whether or not fetus is severely affected, to correct anemia and reverse the hydrops by intrauterine transfusion, and to deliver the baby at the appropriate time, weighing the risk of prematurity against these of intrauterine transfusion. So objectives will be non-immunized women, prevention of alloimmunization, immunized women, early detection, and adequate treatment of fetal anemia. So prevention, screening of all mothers, screening of antibody for Rh negative mother, and administer anti-D immunoglobulin prophylaxis. Yes, must after delivery if the fetus is positive within 72 hours, and after sensitizing event again within 72 hours. That means we saw already that there are certain procedures which we do during pregnancy, or if there is a threatened abortion, or if there is a recurrent bleeding like antepartum hemorrhage, we will have to give the dose of anti-D within 72 hours. The aim of management, again, to predict which pregnancy is at risk, whether or not the fetus is severely affected, to correct anemia and reverse the head drops. Okay, I think we finished this. Now coming to the antepartum. Antepartum, there could be a silent injury or an antenatal procedures. Okay, and if we have know that the FMH is less than 2 ml, then 50 microgram dose is sufficient. Intrapartum, again we know that if the mother is having a large fetomaternal hemorrhage, with these conditions she can have, like instrumental delivery, LSCS where the rate is now more than 40%, if we have done a manual removal of placenta, and if there is a IUD, or if there is an abdominal trauma during the 3rd trimester, or if there is a abruptio placenta, all these patients will definitely require more than 300 microgram, because usually the dose which we give is 300. But if there are some insults where we expect that there are more fetomaternal hemorrhages happen, we may have to give more. Now, they will require, and who cares for calculating the dose? How many center has got facility to measure FMH even by the Klehor-Betke test? We don't have. So clinically also, if we suspect that there are chances of more fetomaternal hemorrhages, it is better that we give them a large dose. Now, the recent concern which I always feel nowadays is upsurge in Rh alloimmunization noted probably due to availability of oral abortifacient drugs. That is, we know, as OTC drug at medical stores, illegally again given, and there is no anti-D coverage. And most of the primaries, when we are talking about preconceptional counseling, we know that they don't know their blood group, and most of the girls, unwed girls also, they take it across the counter. So there are chances of alloimmunization. Now, why Rh negative mother is special? Because there is a difference in antenatal management, intrapartum management, and postpartum management. So we have to know maternal immune status. If not immunized, prevent the immunization, and aims it to detect that who is going to get affected. Now, husband blood group is again important to know whether he is heterozygous or homozygous, particularly in a patient who has lost babies in previous pregnancies. It will help us. Okay. Maternal antibody determination by ICT with titer at first visit is must, then at 26 weeks, then at 32 weeks. If it remains negative, nothing is to be done. We can give antepartum prophylaxis. How much? Single dose of 300 microgram at 32 weeks or 50 and 150 microgram at 26 and 32 weeks. Prevention, again, I said we have to screen all the mothers and administer antiglobulin prophylaxis within 72 hours. If it is not given within 72 hours, a dose given within 9 to 10 days may provide some protection. So by chance, if somebody has not taken the dose, we can give it now. Again, we are really happy to see that anti-D injection is freely available for patients even in government hospital. And I think that will really help in a long way to prevent the isoimmunization. Now, anti-D prophylaxis guidelines. Anti-D is an antibody against the D epitope present on fetal RBC to prevent the Rh negative women from sensitization. Mechanism of action: anti-D immunoglobulin passive injection coats this D epitope and prevent the interaction of maternal immune system with Rh positive. So 300 microgram anti-D neutralizes about 30 ml of fetal Rh positive blood. Okay, that is 15 ml of packed fetal RBCs. It is available as anti-D preparations, monoclonal and polyclonal. Now, if we talk about monoclonal, it is highly specific antibodies against single antigenic epitope produced by the clone of a single hybrid cell formed in the laboratory by the fusion. Advantages of it are specific, consistent, uniform, safe from transmission of viruses and harmful proteins. And currently, I think it is only monoclonal which is available. The advantages: manufactured by hybridoma technology, no pooled plasma involved in manufacturing processes, provides monoclonal anti-D, no batch-to-batch variation, unlimited production, no risk from emerging diseases like CJD, parvovirus, and superior technology. Benefits: higher specificity of action, no shortage unlike polyclonal anti-D, undoubted safety, uniformity of product with competitive pricing. Polyclonal is derived from sera of immunized humans made up of mixture of antibodies with affinity for a wide range of antigenic epitopes. Sorry, difficult to manufacture in large quantities, difficult to provide consistent batches, and chances of transmission of infection and harmful proteins. So these are the guidelines for anti-D of a different countries. That is postpartum. ACOG 300 microgram within 72 hours. Almost it is, I think, uniform for all. Sensitizing events for ACOG less than 12 weeks, 50 to 120 microgram, more than 12 weeks, 300. RCOG less than 12 weeks, or ectopic pregnancy, or molar, or MTP, or heavy uterine bleeding with pain, 250 international units. 12 to 20 weeks, 250 international units, about 20 weeks, 500. FOXY, 300 microgram within, that is for postnatal, and for sensitizing events, the recommendation is 50 to 100. And another group, that is the British Society of Hematology, again says less than 12 weeks, ectopic pregnancy, molar, same, I think, like RCOG. NHS again 500, maximum dose they are giving 500. SOGC less than 12 weeks 120, more than 12 weeks 300. And New Zealand and Australia, first trimester 250 international units, second and third trimester they have gone up to 620 for 625 international units for sensitizing events. So how do we manage a isoimmunized mother? An anti-D titer greater than 1.4 indicates Rh isoimmunization. If initial anti-D titer is less than the critical titer, the patient is just kept under observation with monthly anti-D titers even from 16 to 18 weeks onwards. Amniocentesis perform only if titer reaches the critical value. Otherwise, with this, we have to just go on monitoring them. Okay. And the mother has to be reassured at 2 to 3 weekly intervals from 17 weeks. Then when the antibody level is less than 4 international units, the fetal hemolysis is very mild and pregnancy can be allowed till term with a spontaneous delivery. But when the antibody levels between 4 and 8, there is a moderate hemolysis and we have to be warranting delivery at 30 to 38 weeks with a neonatal transfusion being required in 55% of cases. When antibody levels more than 10, international units per ml, the disease may be severe and needed further investigation. Women who are already sensitized should not be given anti-D, that we know. Now, again, we have to screen them at 20 weeks, 24 weeks, and 28 weeks of gestation. Okay. It again depends on if the father is Rh positive, and we have to look at this. Now, if the anti-D test is negative, antenatal anti-D prophylaxis. At delivery, you have to check the blood group of the baby, and then if the baby is Rh negative, we don't have to do anything. Rh positive, 300 microgram of anti-D within 72 hours. Okay. But if it is positive, we have to manage a sensitized pregnancy. We may have to do amniocentesis for estimation of fetal bilirubin levels, where the optical densitivity is at 450 nm. Further management is based on fetal condition as determined by percutaneous umbilical blood sampling, amniotic fluid analysis, ultrasound examination, and Doppler ultrasound of middle cerebral artery. I must say, now as we are looking at the peak systolic velocity on MCA, that really helps us to assess anemia, and it is a non-invasive technique. Okay. Now, if ICT is positive and it is a first sensitized pregnancy and there are no prior severely affected pregnancies, then we have to manage them non-invasively with MCA Doppler to diagnose fetal anemia. Repeat antibody titers again every 4 weeks. We have to look at husband genotype, and titers we have to go on checking. Previously affected pregnancy, or there is a past obstetric history, we have to look at the husband's blood group to know whether it is heterozygous or homozygous. And past obstetric history is the predominant indicator of the current pregnancy outcome. Frequent follow-up almost weekly for MCA peak systolic velocity. Fetal transfusion can be offered as early as 16 weeks. Watchful in your fetal evaluation when fetal age reaches 6 weeks before last mishap in present pregnancy. Means we'll have to be very careful. Okay. Suppose last time it had happened at 34 weeks, then 6 weeks prior. Follow up again with MCA Doppler and delivery when your neonatologist is comfortable. Okay. This chart again we look at the ICT, whether it is negative or positive. Okay. Negative, we already discussed about the anti-D prophylaxis. Okay. And for ICT, or we can look at the MCA and peak systolic velocity, and no treatment is required, and follow-up scan can be done at 32 weeks, and we can give a second dose of prophylactic anti-D. Here the mother is negative, ICT negative. But if she is positive, okay, and if the husband is homozygous, that means each baby is going to be Rh positive, early prophylactic transfusion may be considered, that too with a history of previous pregnancies affected. If we look at the critical levels of the ICTs, whether it is less than 1:32 or more than 1:32. If it is less than 1:32, follow up every 2 weeks after 20 weeks with ICT, and again look at the peak systolic velocity of MCA. There are signs and symptoms of any of the following: severe fetal anemia, MCV is more than 1.5 MOM, increase in ICT titer of more than 4 folds than the previous titer, then we will have to go for fetal blood sampling, and we will have to do all these tests, that is CBC, direct Coombs test, blood group, and RH on fetal blood. Fetal hematocrit is less than 30%. Fetal age is more than 35 weeks, we must deliver. If it is less than 35 weeks, then there is a role of fetal transfusion, and as per requirement, we may have to repeat the transfusions. If the fetal hematocrit is more than 30%, then again we will have to reassess this baby by regular follow-ups. So fetal anemia is the worst complication. Ultrasound has a key role to be done as early as possible to establish the correct gestational age, fetal anemia, cardiac signs like fetal cardiac function test, and all these things should be done. There is an addition of fetal HQ recently, which I just tried to find out, that they can really look at the shape of the heart and so many things on software. The other things which we look at on ultrasound is abdominal circumference, HCAC ratio, intraperitoneal volume of fluid, extrahepatic vein diameter, placental changes, length of right lobe of liver, splenic perimeter and enlargement, Signs and symptoms of impending ascites, double outlining of hollow viscera, which we call it as a Buddha sign. Even, I mean, if it is around the skull, that is that hollowness, that edema around the skull, that is Buddha sign. But you can see double outlining of hollow viscera, that is stomach, gallbladder, urinary bladder, and hydrocele. Okay, all of us are used to this. We have seen most of the time these pictures where you can see the edema around the scalp. Cardiac signs will be effusion larger than 4 millimeters or biventricular outer diameter in millimeter greater than 1.1 times the number of weeks. So fetal anemia, we have to look at peak systolic velocity of the middle cerebral artery. It is a proven method at 95% confidence level positive, likelihood ratio of 8.45 negative, and likelihood ratio is 0.02. That is, positive is 8.45, negative is 0.02. It can be obtained at weekly basis, gives 98% acute prediction of fetal anemia. So we don't have to do any invasive techniques. Other treatment modalities are plasmapheresis, intravenous immunoglobulin, combined approach, oral tolerance with oral anti-D positive antigen is not good, and chemotherapy with promethazine. Now the transfusions are again of two types, intravenous transfusion and intraperitoneal. Intravenous is done in umbilical vein, intrahepatic vein, and IVT is the method of choice today. Intraperitoneal is practical method when there is difficulty with access to the umbilical vein or intrahepatic vein. So approximately 1% of hematocrit decreases in fetus after the intravenous transfusion due to the disease process. So immediately you may find there is a decrease in hematocrit. And there is a software-based calculation where they decide that how much RBCs need to be transfused. Fetal medicine specialist people will be able to give us the correct idea, but we are happy to know that it is the software which tells us that what is the coefficient and what is the target to reach and of the fetal hematocrit. So what is the target is we have to reach up to 40 to 50% of correction. That is the thing which I can learn from this, that much correction is required. Because if we have done is more, then there could be fetal polycythemia, hyperviscosity problem. It can happen if 65% of hematocrit value is obtained. So there could be problems. So up to 40 to 50% correction is required. Source of RBCs, yes, O negative is the group of choice and it must be tested for all the infections. CMV seronegative, leukodepleted, fresh unit gives high 2,3 DPG and irradiated blood. Now coming to the timing, neonatal backup facilities are must. Up to 35 weeks, we have to monitor with MCA Doppler. After 35 weeks, after steroid, one can plan for delivery. There could be problems during transfusion. If it is posterior placenta, fetal hive drops, multifetal pregnancy, early gestation, because there are papers where they have done it early. Definitely the cord will be very smaller in diameter, fetal anesthesia and timing of delivery. Donor blood hematocrit to be checked, availability of irradiation, CME negative product, leukodepleted products and O negative blood. So what are the do's and don'ts? Cardo and transfusion, size of the needle, 20 or 18, echo, tip advantage to be taken, not by regular needle, long spinal needle. It should not be too thin needle, don't overload the fetus, not to under transfuse, and repeated procedures and least procedures are preferable. So first sensitized pregnancy, no priorly severely affected pregnancy, the past obstetric history as I told you, ICT positive titers are managed non-invasively again and again with antibody titers every 2 to 4 weeks and MCA Doppler. Okay. Husband RA genotype, if it is known, then frequent follow-up. ITC can be IPT, intraperitoneal transfusion can be done as early as 18 weeks and then can be done after 24 to 26 weeks and again follow up with MCA Doppler. Okay. If there are, what are the indications now for this? Any USG findings suggestive of severe fetal anemia, sudden and significant rise in antibody titer level 4 times, neonatal disease requiring excess transfusion in previous pregnancy and previous IUD due to RH disease. So whenever the fetal blood sampling is indicated. Blood should be available immediately for intravenous transfusion if anemia is detected. That means whenever we are doing the fetal blood sampling, we should be ready with the blood, because if the hemoglobin is less than 30% or less than 2 standard deviation of that gestational age, we should be ready with the blood. And timing, as we already discussed, depends on neonatal backup, up to 35 weeks MCA Dopplers, and cord blood investigation at the time of delivery should be blood group, direct Coombs test, CBC with indices, and serum bilirubin. Okay, so dear friends, we have to see to it as a obstetrician, if the fetus becomes hydropic during our antenatal checkup of a Rh negative mother, most important step is proper management of Rh negative mother. So in summary, prevalence of Rh negative pregnancy range from 5 to 15%. Rh negative mothers bearing Rh negative fetus has high chance of developing antibodies against fetal RBCs. Rh positive fetus or babies born to sensitized Rh negative mothers have high risk of developing hemolytic disease of newborn. Sensitization in Rh negative mothers can be prevented by giving anti-D prophylaxis in the postpartum period and sensitizing events such as abortions. Monoclonal anti-D preparations offer advantage of specificity, uniformity, consistency, and safety over polyclonal. Management of sensitized Rh negative pregnancy requires frequent monitoring and expertise of intrauterine blood transfusion. Thank you very much for your patience, and sorry for the technical disturbances.
Madam, thank you so much for that elusive talk. Such a mammoth topic you have covered very nicely. Right from how you should be investigating the patient at the first visit to even her husband investigation is necessary, and then how if she is sensitized in between, how do we manage that, how do we plan the delivery, right? Everything, and post delivery also what can be done for the fetus. So I guess this has been really a wonderful talk and we have understood it very well. There are a few questions. Should we take the questions right now?
Yes, Varsha.
Okay. I think the first question is by Dr. Maheshwari. How to proceed in Coombs test positive mother at 20 weeks? I think ma'am, you have one of the slides showing how you manage it, na? Sensitized mother.
Yeah, you have to look at the titer.
Yeah.
Okay. Now the titers, I said that if the titer is less than 4, we don't have to worry. There is a mild sensitization. If it is 4 to 8, you will have to monitor her very, very carefully. And as every 4 weeks you go on doing her titers, and if you find suddenly that there is an increase in 4 times, that means it is worrisome. And we will have to think of, if it is less than 32 weeks, 34 weeks, we will have to think of intrauterine transfusions. But if there is no increase in the titer, we can go up to 38 weeks and deliver, but we will have to do the fetal surveillance. We learned by ultrasound, best way is a MCA, peak systolic velocity, which is the best predictor of that. Okay. And if the titers are critical, that is if it is 1:32 more than that, then we know that we don't have much time. We will have to interfere early. We will have to diagnose fetal anemia, and we may have to do intrauterine transfusion if the pregnancy is less than 35 weeks of pregnancy. And you will also have to look at the neonatal backup.
Another question is there a list of such clinically significant antigen donor list which can help during transfusion if required for these patients?
I think now we have such updated blood banks, and the amount of blood required is very less. It is only O negative. And the amount of blood required for transfusion is not so high. So it's okay, O negative blood is easily available and can be taken, and they all investigate them for infections and everything. So that problem is not there.
One more
I think now I'm a PPH lady, and I keep saying that every obstetric unit must keep a O negative blood ready.
Yes,
because if it is a class 4 hemorrhage, there is no time for cross match. Okay. So obstetricians are already ready with O negative blood.
So O negative patients are very, very important to us for this and for PPH also. Yes. Another last question, ma'am. Are we supposed to give anti-D prophylaxis to each Rh negative mother or have to get antibody testing done?
See, we have done her ICT at first visit. We are going to repeat at 26. We are going to repeat at 32 weeks. Now, here in India, what we are practicing is we give one shot of 300 microgram of NTD at 28 weeks. Okay, we are giving at 28 weeks. Okay, and then post delivery, after we check, if the baby is negative, we don't have to repeat. If the baby is positive, again we will have to give one more dose of NTD within 72 hours.
Right. So I think we have come to an end of the talk, and that was really...
One more thing I would like to tell, because I only had that doubt, so I found out. So if you have a patient who has recurrent bleeding during pregnancy and she is Rh negative, what do we do? Okay, she has bleeding, we have given her NTD. Okay, now she again bleeds, when to give? Okay, so that is always a question. So in that case, we can wait for 4 weeks, because the half-life of the NTD which we have given is about 4 weeks, and depending on the duration of gestation, we can repeat the second dose after 4 weeks.
Okay.
Okay. So
that's really a good question and answer also, ma'am. Thank you so much.
Sheila, I wanted to make a comment because recently, just last week, I had a patient. She's a second gravida. First was a term cesarean done, and she had a stillbirth, 3.5 kg baby, and they have not realized she was Rh negative. Oh. Then now she's pregnant again. In between, they checked she's Rh negative. Now she's 8 weeks pregnant, and she was found to be indirect Coombs positive, 1 in 8. So she was scared, scared so much by the consultant.
Yeah.
So I think our counseling in the initial thing is very, very important. Tell them 1:8. We can manage. We should manage. We'll repeat your indirect Coombs if the percentage is going up, the ratio. Secondly, we have a method of monitoring the middle cerebral artery PCV. And whenever it is required, we will act. Yes. So I think that confidence we must give to the patients.
I think one lesson I have learned with Rh negative mothers, the first pregnancy is very important, because she is a primey, she is not sensitized. So Rh negative primey, we have to see that we give her a good outcome, because this is not a sensitized pregnancy, and if she gets sensitized during this pregnancy, or if something happens, then the second pregnancy, she will definitely have problems. So it is always a primary gravida, Rh negative mother. We have to see that we have really taken care of her. And
I think we are not doing indirect 32 weeks. We are doing once at booking.
No, we have to repeat.
28 weeks before we give the NTD.
Yeah, after giving NTD, again, if you do ICT, it might be slightly positive. You may get 1:2, but we don't have to get scared. Yeah. Okay. So that also we have to keep in mind. The titers will be very, very mild, because we have given her 1 antenatal dose of NTD. I still remember one patient, because when HIV concept had come, NTD had gone out of market. Poor patient, breech delivery, was delivered vaginally. She lost that baby. She was not given NTD. The second pregnancy, she came to me. She was sensitized. We could not save that baby even after doing intrauterine transfusions. I'm talking about 90s. Okay. So from that day, I learned that the first pregnancy for a Rh negative mother is very important. And another message has to go, that every girl has to know her blood group, not only hemoglobin.
Yes.
Because we are looking at the medical abortions causing isoimmunization. At least if we bring the awareness that Rh negative, I think we have to really spread this awareness now, not only for preconceptional, but every woman, every girl, if she is Rh negative, she has to be careful.
Yes.
Thank you very much for
and that girl should know whom she is marrying. Her husband's blood group should also be known.
No, I think that will create more problems.
And blood dene ka kaam pada, to if he is negative, we can use that.
Thank you so much, Dr. Sheila and Varsha, for that wonderful session on Rh isoimmunization. So friends, let's go to the panel discussion, which is much awaited, as pregnancy after 40 has increased tremendously, I will say, in the last decade. So we have the moderators, Dr. Chaitanya Shembekar and Dr. Rohan Palshetkar. It's a pleasure to introduce dear friend Chaitanya Shembekar, who runs the Omega Hospital at Nagpur. He is past president of Nagpur Society, currently chairman of Infertility Committee AMOX, and he is executive member of Maharashtra ISA. Friends, he has been there in many organizations. He is a great academician and he has got many publications to his credit. And more so, he is a fantastic orator and a writer. I am a fan of Chaitanya Shembekar. So, Chaitanya, welcome you for this panel discussion. Our
Thank you,
next
madam.
moderator is Dr. Rohan Palshetkar. Rohan is head of the unit of Bloom IVF at DY Patil. Currently, he is second joint secretary AMOX and he is managing committee member of both MSR and Mumbai OBGY Society. He is associate professor at DY Patil School of Medicine. Friends, he is the recipient of so many young awards, AOFOG Young Gynecologist Awardee, Foxy Korean Awardee. He is Yuva Orator and he is the ISAR Yuva Orator. So welcome Rohan. I am happy to have you on this platform.
Thank
And
you.
it's a pleasure to introduce Dr. Seema Pandey. Seema is a dear friend from Azamgarh. She is president of Azamgarh OBGY Society. She is a national executive committee member of ISAR. She is past secretary of UP ISPAT chapter, past editor of ISPAT newsletter. She is organizing secretary of UP chapter of ISAR. Friends, she is an academician and she has got many publications. She has edited books. She is editor of journals. She has received many awards. So Seema, I welcome you as a panel expert for this panel on pregnancy after 40. So I hand over the mic to the moderators for further proceedings.
Uh, Thank you, Dr. Lakshmi. Special thanks to ISOPUB, Dr. Lakshmi, Dr. Sneha Boyer, of course, Dr. Milin Shah, and Dr. Alka for giving me this opportunity, along with my co-moderator, Dr. Rohan Pashetkar. I am not able to do the screen sharing, I think. The session, can you please help me?
Chaitanya, he's showing you the CVs of the panelists. You can introduce
Okay.
them in 1 or 2 lines.
Okay, I'll do
And then
that.
you can
Okay.
go ahead with the panel as we are already
Okay.
lagging behind time. Yeah.
Okay, great. So we have with us a wonderful panel. We have with us Dr. Kamini Patel. She is CEO of Vani IVF Center, Ahmedabad, and we are associated with Dr. Kamini Patel. Welcome Dr. Kamini Patel on this forum. The next panelist is uh, Dr. Priti Niranjan. She is actually past president of Baroda OBGY Society and a great academician. And she is also a IMS menopause practitioner CIMP with special interest in adolescent gynecology and menopause. Next panelist is my very good friend Dr. Nilesh Balkaude, and we are working together on so many projects, and he is always there to help me. He is basically chairperson elect of quiz committee of Foxy and also joint secretary of Pune clinical secretary of Pune OBGY Society, and a great academician with a special interest in quiz and an IVF consultant. Our next speaker is panelist is Dr. Sejal Naik. Dr. Sejal Naik is from uh,
Surat.
Surat. Yeah, she is from Surat, and she is consultant endoscopist and fertility specialist from Surat. Welcome, Dr. Sejal Naik. And the next panelist is Dr. Ritu Hinduja. Dr. Ritu is upcoming IVF consultant from Mumbai. She is a member of ISAR managing committee, and soon she will become a member of MSR managing committee as well. Welcome, Ritu, on this platform. So, with this introduction of and of course, Dr. Priyankur Roy. Priyankur is a very good friend of mine. He is basically from Siliguri, and he is consultant endoscopic surgeon and also a national coordinator of perinatology committee of Foxy. So with this wonderful panel, we are going to start today's panel discussion, and I, along with Rohan, my friend, welcome you all for this panel discussion. So sit back, relax, and enjoy the show. I am also happy to have Dr. Sheila Mane, Dr. Varsha Dore, and so many other seniors with us today for this panel discussion. So pregnancy after 40 is what we are going to discuss today in another 40 minutes or so. So as I have told you, we have a wonderful panel and I welcome you all for this panel discussion. Now you see the changing trends in the clinical practice. 40 is new 30. 140/90 is considered as normal. HbA1c 7, good control. And pregnancy at the age of 52, yes, it is possible. So somebody has said, I don't hate school. I just hate the teachers, the homework, the exams, and waking up in the morning. Similarly, I would say I don't hate obstetrics, but I just hate night calls, this push, the fetal distress, and PPH. But then we all are obstetricians to the core, and we have to, manage the show, and we have to get going with all these problems. So I would like to have a disclaimer that all the characters in this panel are fictitious. Any resemblance is a pure coincidence. Kundli Yog, which I have added, is just to add humor. We do not intend to disrespect Jyotish Shastra. In fact, I personally also believe to some extent in Jyotish Shastra. So I feel that we should start studying Kundli of our patients, see the horoscope, match Guru, Rahu, Ketu with that of the patient, and then only start accepting patients, because we are actually sitting on a volcano which may erupt at any time. So you have to be extremely careful, especially in this era of medico legal problems where people are so aware. We have to be very careful. So we have to have all our things properly in place, and we should try to follow all the guidelines and latest guidelines as far as the treatment of pregnancy after 40 is concerned. So we start with the first case, and this is a case of Nirusha. Nirusha is 40-year-old lady. She is married since 6 years. This is her second marriage and gives history of MTP from first marriage 8 years back. And now she is eager to conceive, and not only eager to conceive, but also wants self-oocytes. So I would like to ask anybody from the panel, anybody can take this question. What are significant points in the history of Nirusha, which I think are important as far as the latest treatment trends are concerned?
Thank you, Dr. Chaitanya, for the wonderful question. Thank you, Aisopa, for this opportunity. Age, definitely, as you have put here, Dr. Chaitanya, is a very important factor. 40 years, and when she wants to go for a self oocytes, then definitely we'll have to consider age to be the primary factor. Now, the thing is, as we all know, that with increasing age, which is a most significant factor of decline in the number of oocytes as well as the oocyte quality, so we have to definitely counsel her that definitely, see, no patient we can refuse saying that you are too old and you cannot get pregnant, or you cannot try with self-X. So if a patient wants to try with self-X, we definitely have to give her that opportunity and let her go ahead with the self-X as well. But the thing is, we have to counsel her regarding the thing. Like, of course, the results we have to explain to them that it might not be we might not be very successful in doing it, but we can definitely give it a shot. So,
Right.
of course,
Yes,
as you have put it here, the stormy in the beginning is another thing, because the pregnancy, a preconceptional counseling and preconceptional care for this patient will be very, very important, because we'll have to all look at the other factors also, like hypertension, diabetes, etc., and then only plan. Because once everything is normal, then the chances of not going into a normal pregnancy will be much, much easier and better.
Right.
Dr.
So, as
Chaitanya,
rightly said, yes,
I would
please.
like to just say that it's
Yeah,
not only the counseling of the patient which is important over here. I think it is very, very important that you have things documented on paper. So if you are going ahead with any woman who's planning a pregnancy post 40, I think it's very important to get a medical fitness on paper. Make sure that you have an obstetric fitness on paper and a physician fitness on paper before going ahead and trying to make this woman pregnant.
Right. So one thing is clear, that you have to be extremely careful while managing such patients. Do proper counseling, and the most important thing is changing trend. Patients, they want their own eggs. So that is something which we have to respect their sentiments, and maybe we sometimes go for self eggs, try for self oocytes. So this is a late pregnancy. This is the horoscope of Nirusha. Late pregnancy, but good result. Stormy in the beginning, but uneventful later. So this is what is her horoscope.
Absolutely. So obviously, as we can see that the patient has a low AMH 0.9, AFC is just 5. Our stimulation, we started with a dose of 375. We did manage to get 4 oocytes. We got 3 grade 1 embryos, and we did a fresh embryo transfer, a day 3 embryos. We transferred 3 embryos, and now the result has come positive. So all the effort that you put in, you counseled the patient, you've done your medical fitness, everything has worked out perfectly. Now, to my panelists, I'd like to ask, on which day post the ET do you usually do a beta HCG? Do you think a 12 days post ET value would be helpful in assessing, especially since we put in multiple embryos? And what do you think the normal value are you expecting at, say, day 12 or day 14? Does anyone want to take it? Dr. Nilesh?
Yeah. So basically, I'm not giving HCG for the luteal phase support. So I'm clear that I'll not have any disturbances by giving this exogenous HCG.
Absolutely.
So yeah, so I will do the HCG 14 days after my transfer, as I'm doing blast transfer. In this case, it was a day 3 transfer, so you expect little bit lower values on day 12. So you have to be skeptical if you are doing it a little earlier. I think 14 days is a fair enough thing to go for beta HCG. And the normal value usually they give as more than 35. But I am myself assured when I am doing a blast transfer, I expect a value of at least more than 100 to give a viable pregnancy. That's what the cutoff I take.
Right. Any correlation with twins? I mean, do you expect? Yes, yes, Nilesh.
Yeah. So yes, I think we get higher values in twin pregnancy. Roughly, if it is a singleton pregnancy, the values are somewhere less than 2000, and if the values are more than 2000, we expect that there can be a multiple pregnancy. Of course, we all know that we cannot be 100% sure. It depends upon the chorionicity and the reaction which has occurred at the micro level. Therefore, we cannot take exact value what it will be. But I think, yeah, higher the values, the more chances of multiple pregnancy.
The most important word which Nilesh said was expect, because it's only expectation that we can have, because we cannot say anything for sure, because sometimes with values of even 3000 and all, we sometimes see it's a singleton pregnancy, and sometimes even with values of 9,200, 1,300, we get multiple pregnancies.
Exactly.
Chaitanya, can I just say something? In
Yeah,
a person who is 40 plus, I personally wouldn't take the chance of doing a 2 embryo transfer day 5 because I don't want to give her a twins pregnancy.
Right.
Can you hear me now?
Right. So that is the reason why we are here. We are doing panel discussion, and I just want inputs from all the experts.
So
that
in a
what they
woman
do
who's
in their
around 40 plus, I would rather counsel her to go ahead with a single embryo transfer, which is actually tested for aneuploidy. So I will do a proper genetic counseling, do a PGTA for this patient, and make sure that I've done a single embryo transfer and avoid twin pregnancy in a woman with increased maternal age.
Right.
I agree with Ritu. I totally agree with her.
Absolutely.
Rightly said, Ritu. So this is how we have to go. Single embryo transfer, that to blastocyst, and along with that we have to go for PGTA so that we know that aneuploidy is ruled out. Now, now this is for actually, since this is the ISOPA platform where everybody has logged in. Those who are not doing IVF are also with us. So we have to know about the correlation of beta HCG with USG. This is sometimes very important because that is what we are going to discuss now. So can anybody take this question? How do you correlate beta HCG with USG findings? Okay. And of course, which type of which route would you prefer for diagnosis of pregnancy?
Dr. Kamini ma'am, would you like to take it?
Yeah, Kamini ma'am, you can take it.
Yes. If the beta HCG is 1000, we should be able to see gestational sac. Around 2000, I am expecting around a yolk sac and a fetal pole. But above 2000, that is 2500 to 3000, I would definitely expect a fetal cardiac activity. Now, if there is any discrepancy around this, I should be looking somewhere else, like single embryo transfer is a protocol at my place, but if some centers they are transferring about 2 to 3 embryos, they should be looking at the other places also whether they are heading up with a heterotropic pregnancy or not.
Yes,
if there is any discrepancy around this.
We'll be getting to that topic.
And I normally do the vaginal scan at the 10th day post beta HCG, and all beta HCG done on 15th day post transfer.
Absolutely.
This is the protocol we follow here. So
Right.
there is no chance that I should be losing any discrepancy around on the 10th day post transfer.
So I think one thing is clear, that there is no role of abdominal scan as far as the diagnosis is concerned.
No.
You should actually not think of going for abdominal scan, which is going to add to the confusion.
Okay.
And this is exactly what we know, that around 1,000 you should be able to get a sac. And then now this patient Nirusha, her beta HCG is 780. Now we have transferred 3 embryos, and do you expect something in from beta HCG levels? Do you anticipate something, or
It's
what?
of
How do you correlate beta HCG levels with your diagnosis? I mean, twin pregnancy, triplets, or heterotropic pregnancy, or ectopic pregnancy, for that matter, whatever.
See, this beta HCG is done on the 12th day 12th day post transfer, isn't it? So I would expect around 98 to 100 per pregnancy on the 12th day.
Right.
So here it is 780. I would be expecting a multiple pregnancy in this case. So I'll be more vigilant in this case.
Exactly. So we have to be more vigilant, and if 3 embryos are transferred, then of course you can think of triplets as well. And it is said that if beta HCG levels are high at this point, one should also suspect heterotropic pregnancy.
Yes.
Now this is something which was missed at this time. Now then USG was done at 5 weeks. Again, there was a minimum free fluid and twin pregnancy, and diagnosis of twin pregnancy was done at 5 weeks. But after 2 days, this patient came with severe pain in abdomen, and there was tachycardia, but she was not pale. I mean, she was not in shock, but she had severe pain in abdomen. So, Dr. Sejal, you can take this question. What is your diagnosis at this point of time?
Considering the 3 embryo transfer and the high beta HCG on day 12, so we should definitely search for the third pregnancy with the tachycardia and pain. So we definitely will do a good scan, transvaginal scan with searching in the adnexa. If there is a tenderness, and if there is signs of any free fluid or peritoneum, and if we can locate the third cell. So that would be my first step, and then we'll investigate further with we'll, in case of suspicious of this heterotropic pregnancy, then we have to definitely manage accordingly.
Can I come in?
Doppler also into this to confirm our diagnosis, color flow.
Yeah, but then one thing that the free fluid when you see in the pouch of Douglas with twin pregnancy, I think that should ring the bell to the consultant.
Yeah,
Isn't
but
it?
yes, in fresh embryo transfer cycle, sometimes we see some little bit amount of fluid, but if it shows some particles or the suspicious of hemoperitoneum, then definitely one should look carefully around.
Right. This is exactly what happens in fresh transfers. We are doing stimulation. There is a little bit of free fluid, so you should have a high index of suspicion, and always think of possibility of heterotropic pregnancy. Usually, what happens that we see intrauterine pregnancy, we are so elated, so happy that we usually forget or tend to forget, and we don't see the adnexa. We miss heterotropic pregnancy. So the take-home message is very clear that you
One
should
has
be
to
very
be ectopic
careful.
minded.
In fact,
Yes.
every patient, once we get a beta HCG positive, I don't do the OB scans myself. But whenever I send it to my radiologist, I always tell him that just don't look at the intrauterine. Please look at the adnexa as well, because we are doing IVF. At our center, we do put in 2 embryos. So I do want to be careful that I don't end up in a heterotropic, because early in my career, I did have one heterotopic pregnancy, which I did miss. Luckily, I had my seniors with me at that time, so it was caught well within time. So it
Right.
just it made me suspicious every time. So every time I get a positive one, I always tell my radiologist, please look at the adnexa as well. I know how many embryos I've put. If you're just seeing a single pregnancy, look if there's another one in the adnexa. Take your time.
Right.
Yeah, so obviously, as we can see that the incidence of heterotropic pregnancy, if you look at the literature in normal pregnancy, when it's a natural conception, it's 1 in 30,000. So it's quite rare. But when we look at our own IVF procedures, as we were just discussing, each one of us, it's almost 1:3 in 100. And if more than 4 embryos are being transferred, I think that practice is coming down, but there are some places which could be happening.
Still, yeah.
The pregnancies could be even 1 in 45, the heterotopic. So when you're doing IVF, please keep a high degree of suspicion, especially when you're looking for a pregnancy with high beta HCG at an early time. Sometimes you may be practicing only obstetrics. Take a proper history about how the conception is. If you've seen 2 intrauterine pregnancies, sometimes you may even have to elicit a history of ART treatment from the patients itself. So be vigilant and have a high index of suspicion.
Can I add one thing here that even we need to see for the tubal factor if there was any tubal factor infertility associated,
Yes.
because we always know
MTB
that
was done in this patient.
Yeah, unilateral tubal block, if it is there, or if there is any tubal infection, that itself is a risk for heterotopic and ectopic pregnancies.
So I think Dr. Preeti, I just a quick answer from you. You are a senior gynecologist. Have you really seen so many patients with heterotopic pregnancy in your day-to-day practice? I mean, people say that it is so the incidence is 1 to 3 in 100. Is it so high? I really don't know.
Preeti ma'am, you're muted.
Yes, we have seen. We do get heterotropic, but is it so high?
Yes, I have seen one patient.
Yes, ma'am, we can hear you. Preeti ma'am, we can hear you.
Yes, yes.
Yes.
She's muted again.
I feel, Dr. Chaitanya, we have all seen one heterotropic pregnancies in our practice. I don't think we've seen more than that. Except for, of course, Kamini madam must have seen a more, maybe more because she's practiced more than us. But I can say for myself that I've only seen one heterotropic pregnancy in my practice so far.
I have seen 3.
Yeah, I've seen a couple. But the thing is, the important thing right now is basically we all know that the Western literature also says this, that even a multifetal pregnancy is a failure of IVF. So we all need to come to that consensus. I totally understand that with this competition that is going on, we want to have a positive pregnancy by hook or by crook, but we have to understand that it's a single.
So this is a very important
I'm sorry, Priyankul, positive pregnancy has nothing to relate to the number of embryos that we transfer. I feel a good one single embryo transfer can give us a pregnancy if it has to.
No, Ritu, that is very true, but the sort of psychology that goes around over here, that we try to transfer more to get a positive pregnancy, sort of what the people normally is the understanding that goes around. That is very true. Of course, a good endometrium with a good embryo is where we can get it, and even a single embryo can give us a good pregnancy. But then again, the thing is, it's a single embryo that we all need to slowly come down to. I think it boils down to that. I think that's what we.
That's a very positive
to forward to.
By Ritu and
I am Dr. Seshikala here. May I add a point?
Yes,
Almost
madam,
12 years earlier, we had heard Dr. Paul Deveroy once in Spain, and he was always, since then, he's been advocating single embryo transfer. I am not an IVF person, I am a general practitioner, but I see a lot of heterotopic pregnancies after they conceive. So I think you should, all the IVF people should have your own forum and then make sure you only put in one good embryo.
I think it is moving towards
pregnancy is safe, especially if the woman is elderly. You don't want to add to her problems.
Absolutely.
I think this is exactly what I wanted to convey to the audience through this case. See what happens. There is a temptation of putting more embryos, especially when embryologists usually say if the age is more than 40, put 4 embryos. So that is what many people still do. And this is something which is the practice which we all should stop doing. So this is what is the take-home message from this case. Ron, you can take this.
There is last article. There is an article in
Nilesh.
Fertile Sterile this February.
Yes,
So this
Nilesh.
February we have an article in Fertile Sterile which says that even if we put a single embryo, the cumulative success rate is not hampered. So
Right.
we will get a less success for that cycle maybe, but the cumulative pregnancy for the number of embryos is not hampered.
Absolutely. And I feel, why should you put all your eggs in one basket? You are reducing the number of attempts that the woman is getting. So I rather do
Exactly.
one single embryo. And as Sasikala madam said, I am very scared of the obstetrician calling me back and saying, "Ye kya karke bheja hai mere paas?" So very
Right.
safe.
But you know what, Ritu? The thing is, this myth is very prevalent in the patient also. When the patient is coming from other centers with a failure, and now the counseling starts and we tell that this is our protocol, we are going to do frozen all and a single embryo transfer. The patient is asking that how many embryos you put.
Yes,
We tell normally that one only. She said, "Oh, how am I supposed to get the pregnancy in one embryo, And this myth is so prevalent in the patients also.
I agree.
That no, you
So,
can get pregnancies with one embryo transferred.
So we have to change this.
I think the entire and a lot of the couples come asking that is it possible to get twins? I think that mindset
Yes.
also needs to be
We
changed.
have to break it.
I usually tell my couples that twin pregnancy is a complication.
Failure.
It is not
failure.
me getting you
Frankly.
pregnant.
So getting back to
Actually.
the complications of IVF, the heterotropic pregnancy which we were managing right now. So I think I would want to ask. I think it's Dr. Seema Pandey there right now.
Yes, Seema, our
Can't
expert
see
here.
her.
Yeah,
Seema, where are you?
He's muted.
yeah. I
She's
think-
Ma'am,
Hello.
Yes, probably Seema is not there. She is muted and I can't see her.
So, Priyankur, what would be your preferred route for management if it's a heterotopic pregnancy?
Rohan, there are ways people talk about. They do talk about KCL into the like I worked in Dr. Vineet Mishra's center and he started with this thing of going transvaginally, taking the needle like the pick up needle into the ectopic sac and putting in KCL over there. But frankly speaking, with a heterotopic pregnancy, when you also have obviously a live pregnancy intrauterine, my way of going to it is a
Laparoscopic.
laparoscopic salpingectomy or whatever, and finish it off once and for all.
Right. I think that is the best approach.
I think most of us are
But we have to know one thing: until if the thing is going for a tubal abortion, where we can see that there's something hanging from the tubal end, that is one place where we don't go for a salpingectomy is okay. But laparoscopy is definitely the to-go thing in case of a heterotopic pregnancy with a live intrauterine pregnancy.
There are few case reports. Yeah.
I think
I agree with it.
I think I'd seen Seema Pandey ma'am just logged in for a second. I just wanted her opinion also on it. What does she prefer?
Rohan, I have been logged in for long, but the
I
thing
know, I
is,
know
no,
you're
there's
logged
a
in.
lot of noise going on. So I thought that I will not disturb you, and you guys are doing excellently
Hi.
well. So
Hi, Seema.
yes, please ask me the question. Hi,
No,
Chaitanya,
Hi,
Ritu,
Seema.
Nilesh, Dr. Preeti, everyone.
You are our expert, so we just want final comment from your side as far as heterotopic pregnancy is concerned.
So would you prefer
Yes,
would you prefer doing a fetal reduction with KCL or would you prefer doing a laparoscopic salpingectomy in
laparoscopy. Last year, it was my first heterotropic pregnancy. I had the lady's got a baby boy also, but I would like to go for laparoscopic treatment rather than going for something which goes amiss or affects my another fetus.
Absolutely. Another thing I would want to put across to my panelists as well is, okay, you're managing this patient. Do you think of giving any additional progesterone or any additional luteal phase support because you're managing this heterotopic pregnancy, or do you continue your regular luteal phase support?
I would continue the regular luteal phase support, whatever the progesterone support we are giving. Like this laparoscopy would not disturb the pregnancy anyway.
Absolutely.
So I would not.
So I think we'll quickly move on to.
So much of so
Hi,
many.
Kamini.
Hi, Seema.
Now
You would
that,
anyway not disturb. You're bringing so much light in the panel.
She is our expert. So already now we will not discuss much about other factors related to this case. So all is well that ends well. She ultimately delivered healthy twins. and that is what is actually what we want. If you are able to manage heterotrophic pregnancy and continue with the pregnancy, that is the best part, and it gives you immense satisfaction. And it's really good for the patient as well. Now I just go to the next case, and I think we have so many things to discuss. So we will go with the next case, a case of Mala Pise. Mala Pise is actually a known case of PCO, and she is obese and hirsute, and she could never conceive because of PCO, and because of anovulation, she had suffered a lot in her life. Now she's 41. She's 41, and this is the horoscope of Mala. There is a late conception in her horoscope, and this is a surprise conception. This is exactly what happened, and her pregnancy is going to be eventful, and we have to discuss the events associated with this pregnancy at the age of 41, and all is well that ends well. That is what ultimately happened with Mala. So Mala never thought of going for IVF because she could not afford. She has given up, and one fine morning she feels she feels nauseating, and then their periods are irregular. So she started thinking why there is nausea. So she did her UPT, and it was positive. Now, since we have Seema with us, we start with Seema, I think, and then maybe we can go to other senior gynecologist, Dr. Preeti. That is it possible that patients with very high AMH and classical PCO, they at later stage conceive spontaneously?
Yes.
Seema ma'am.
Yes, sir.
Hi, Chaitanya. Are you asking me?
Yes, Seema.
First of all, let me tell you, I love this horoscope thing. It's something so unique and spot on. Yes. So please repeat the question. I did not hear it clearly.
The question
You
is
wanted me to know if it's possible the patient with PCO and image more than 10 at young age. Oh yes, it happens so many times, and it has happened in my family too. One of my cousins, she delivered at 43 spontaneously. It was a surprising kind of pregnancy. She thought she is undergoing menopause, and when she was checked, and she was found pregnant. So that thing happens with PCOS ladies, and it is not a rare phenomenon. And especially with bad phenotypes, very high AMH, yeah, it could happen easily.
Yeah, Dr. Preeti, what is your take on this?
Yes, you are right. One of my patient is conceived. She's 42, and it's a spontaneous conception, and she's a PCO patient.
Right.
So it can happen very well.
There is anovulation, but then as the age advances, their AMH levels go down, and maybe
and that's why they may
ovulate.
They get settled. And many times after first IVF, second conception becomes natural after age of 37, 38. These patients, they conceive naturally too.
So they say once a PCO, always a PCO. Do you keep a follow-up of PCO in later life? Preeti ma'am, PCO patients, do you keep a long-term follow-up, whether they have a risk of DM or C endometrium or hypertension or metabolic syndrome development?
Usually what I do whenever PCO patient comes to me, we have got a printed proforma in Gujarati. So we give it to them, and I tell them personally by sitting that you are probable candidate for all these things. Sometimes patient may not come back to me, but they had been already informed that they may be diabetic, they may be hypertensive, they may having the lipid profile problems, and they may have the long-term consequences of the PCO.
I think this is very important, and it's a very good idea. Something which Preeti madam has told us, that give them something, give them idea that, because if you are a fertility consultant, you start with ovulation induction, she conceives, and then she is gone. Then you are not bothered about what is the possibility in the later life. So this is something which we all do as a moral responsibility, as a social responsibility. If you are a fertility consultant,
Chaitanya, I will like to add one thing. Whenever I explain, I tell them that I'm not scaring you. I'm counseling you for the long-term consequences.
Yes, the way you counsel is very important. Yeah,
it's such a simple thing what you're doing by giving them something written in the local language, which is going to allay their anxiety. Even if they may not understand it at your clinic itself, they can always go home and take a quick read about it. And if they have any questions, they can always come back later with questions for you. Okay, Preeti, Kamini ma'am, the next question is for you. Do you think this patient is going to develop PIH? And in basically what I'm saying is, do PCO patients have a higher chance of developing PIH in patients?
Yes.
Considering her age also.
Yes,
Exactly.
because she is above 40, and of course, she's obese. In the first slide, it was shown that she is obese. So definitely, we have to be very vigilant in this case, not only for hypertension, even for diabetes.
In fact,
So consecutively, we should be having a physician side by side, that whenever she comes here, she should be consulting a physician also side by side. This is what I would suggest.
Exactly.
And a fetal medicine expert.
Right.
At the age of 40.
The third thing, what we need to, because of our age, we need to be looking for that also.
Absolutely.
Right. So
these are the three things we need to look.
Which are important. So as Dr. Kamini has rightly said, we have to think of diabetes, hypertension, then possibility of course, the other things like anomalies. At 22 weeks, her anomaly scan was normal. Everything was normal, and she did not develop PIH till the gestational age of 22 weeks. Now, what about uh, uh, diabetes? Now we will be focusing more on gestational diabetes and diabetes in this patient because she is PCO and there is always a possibility of diabetes. Now, in case of Mala, this is an unplanned pregnancy, so there is no question of counseling, pre-conception counseling. But if at all she would have come before conception, in case of planned pregnancy, what do you do before conception? For this patient, a known case of PCO now coming to you at the age of say 39, 40, interested in conception, and she says, I don't want to go for IVF, but suddenly, spontaneously, she may ovulate once in a while and she may conceive. So you can give her a chance. So what do you do as far as the counseling is concerned?
She's given all chances of preconception counseling.
Yes,
The
Nilesh.
counseling about the pre checkup about the thyroid levels, even the HbA1c levels are very important in such kind of patients. So blood sugar fasting in PP is important, but I think HbA1c levels more than 8, 8.5 will tell you that there are high chances of congenital anomalies in such patients. However, nowadays fetal medicine specialists say that there is no need of termination of pregnancy, but it is always prudent that we bring down the HbA1c levels, achieve a control of sugar levels, and then she goes for a pregnancy.
In fact, as what Ritu said at the start of the talk in the previous case, that at the age of 39, 40, we should possibly get a medical fitness done for the patient,
Exactly.
at the age of 39, 40, if she is planning a pregnancy.
Right, Ron, I think echo is also very important.
Yeah, just one question I wanted to ask regarding your preconceptional counseling. Considering she's a PCO patient, I just wanted to ask if you had started forget metformin. You do how many of you start metformin and myoinositol for PCO patients? Can I just get a quick opinion?
Myoinositol.
In those category of patients
Only
where it
in
is
cases
actually
where
required.
there is a documented insulin resistance. Insulin.
So do you continue throughout the pregnancy then in such cases?
No,
No,
it is a case of glucose intolerance.
to 12 to 14 weeks max, and then we monitor the glucose level, and accordingly, if she develops the further gestational diabetes, then we put on insulin.
Absolutely.
Actually, American Diabetic Association guidelines 2018 said that you should not give metformin to such patients, but the latest guidelines, they say that you can continue with metformin till first trimester. That is what latest 2021 guidelines say. And so, as they rightly said here, the preconception, periconception HbA1c is very important, since we are discussing GDM and diabetes, and it should be, our aim is to keep it below 6.5.
Yes.
And of course, we have to look for all the comorbidities like retinopathy, nephropathy, then get the fitness done from physician. All these things are extremely important. Yes. Now,
I would like to add on
yes,
Actually, I would also like to add something.
Yes, Sejal,
in anomaly, I would like to advise such a couple for undergoing fetal echo.
Absolutely. A
At
fetal
24.
2D echo would be this, but generally I think a fetal 2D echo would be done more in detail at around 22 to
24 to 26 weeks.
Yes, Seema. Yes, Seema.
And yes, two things I wanted to add. As Sejal said, that is anomaly followed by echo at 24 to 26 weeks. I wanted to talk about metformin versus insulin. All the latest guidelines related to obstetrics, they are keeping metformin as a first line drug for gestational diabetes mellitus. The reason being, metformin is giving better control of weight during pregnancy to these patients, and both of these drugs, they are not preventing gestational diabetes mellitus in these patients if started earlier, and neonatal complications and neonatal admissions are lesser with metformin. So as of now, metformin and weight gain is more with insulin. So metformin has more benefits until unless it is some very unstable diabetes or something like that. First line drug is metformin from SFM, from NICE, from American Association of Obs and Gynae people.
May I also add one point, though I'm not in the panel, one important point, because the question was about preeclampsia. So first trimester early TIFA and then first trimester screening will give us a lot of inputs. Low PAPA and uterine artery Doppler. If it is high, then you have to put them on aspirin, 150 milligrams. And I continue to give metformin and I continue till delivery.
Yes,
because
Dr.
in
Sasikala.
India, it is not the guidelines of the West. India, we have more of insulin resistance. So our women definitely benefit with metformin, and metformin only reduces insulin resistance. So it is not going to be harmful. And first trimester, all these anomalies are reduced by the using the metformin.
I think a very interesting turn in this panel discussion with Dr. Sasikala and Seema, both of them stressing on the importance of metformin, because I had a discussion with, before going for this panel, I had a discussion with my endocrinologist friends, and all of them, they say that insulin is the first line of treatment. But as you rightly said,
No more. If HbA1c and glucose is under control, we can continue with metformin.
Yes. So
second thing, and two more things. Second thing, PCO per se is not increasing the chances of GDM as much as it is increasing the chances of hypertensive disorders of pregnancy. As Rohan rightly put, that was a meta-analysis done in 2020, and PIH is really raised, and anti-scan, TIFA both give us very good clear-cut marker, as Sashikala was mentioning. And second thing, that 2020 and 21 biggest 9 million patients meta-analysis is given this prerogative that it's up to the physician to choose whether to continue metformin till delivery or stop beforehand, and nobody is saying that you should stop it. So I believe firmly in continuing metformin till end.
So Seema is in love with metformin. And
yes,
we appreciate that. We appreciate that. Yeah.
So I think you can see the slide. It's an old study, but it shows that the conversion of impaired glucose tolerance to diabetes mellitus is almost 5 to 10 times fold more in PCO patients. So you can see that in PCO patients, if you do have patients with an impaired glucose tolerance, you have to be more vigilant towards the fact that they can develop diabetes, and you have to do their screening a little more often and be more cautious towards the approach. And considering that she's already 40, it's going to be there. Even in 2015, they said that PCO patients have threefold more increase of GDM. This was a large prospective cohort study which said that 22% patients of GDM have a larger risk. Basically, PCO patients, 22% of them develop GDM.
GDM.
Basically, you have to be a lot more vigilant towards PCO patients who conceive and keep a track of the sugar test throughout maybe all 3 trimesters, not just the second trimester,
First and second
trimester. The DIPSI test.
Yes, Rohan. I think now we are coming to the point. Now the next point is when to do the screening. The patient, this patient coming to you with early pregnancy, when do you screen? Do you ask her to come next visit and we'll do screening, or do you do it immediately whenever she comes to you?
All high-risk patients have to be screened immediately.
Immediately.
And in each trimester. They say that DIPSI test should be done in each trimester.
Yes, I think this is extremely important. So how do you go ahead? Nilesh, you can take this question. How do you go ahead? I mean, what do you do in your clinical practice? Whether you advise HbA1c in the first visit or you do random sugar, or you do fasting post meal, or you do GTT? How do you go ahead,
Yeah.
step by step?
So if she is already
Diabetes.
diagnosed to be having a glucose intolerance, then I think fasting and post meal along with HbA1c is better. But if we are screening the patient, then we do a DIPSI test where a random sugar where it is not related to the, it's not random sugar, it's not related to the her meal intake. She needs to take glucose 75 gram, and 2 hours after the glucose intake, we take a sugar level. If this sugar level is more than 140, we label it as gestational diabetes mellitus, or if it is below 20 weeks, we'll call it as glucose intolerance. And more than 200, we'll label it as diabetes mellitus.
This is Cheshaya's DIPSI test.
Yeah.
And I think now that we are discussing DIPSI, we will go into more details about DIPSI. But before that, as rightly said by Nilesh, step number 1 is to do HbA1c along with fasting post meal. If the sugar levels are high, then there is no question of doing GTT.
Yes.
But if the sugar levels are normal, you should do GTT as early as possible, especially in India. And this is a take-home message which we all should remember, that even if the patient comes to you for the first visit and you do HbA1c, just a screening, next visit you get her GTT done. Do not wait for 24 weeks for GTT to do, because you may get many patients, especially with gestational diabetes, with diabetes which is missed, and therefore you do GTT. But GTT is not a test for the monitoring of sugar, or it is not a test for the control of sugar. It is the test which is for the diagnosis of diabetes. Once the diagnosis of diabetes is done, there is no role of GTT. Then you have to do the screening with sugar levels. So this is very clear. But now this very interesting topic which Nilesh has touched, and I want opinion of everybody, because I have seen there are two groups of endocrinologists in India. Even in Nagpur, we have two groups of endocrinologists: those who love Sheshaya and those who just do not accept or do not agree with DIPSI test. So I just want quick opinion from everybody, that how do you take DIPSI test? What is your take on DIPSI? Do you like it? Do you think it is a good test, or do you think it is not a good test? Because then we will discuss all the points related to DIPSI.
I do a DIPSI test in each of my patients whenever they come, and in each trimester. After attending one gestational diabetes workshop, you can say conference at Ahmedabad. So it is in my protocol.
Okay. And
I'm
then
convinced with it.
Okay. Anybody else? Sejal, Dr. Sejal?
We don't do it.
You don't do DIPSI.
No.
Okay. So Dr. Preeti says we do DIPSI. Dr. Sejal says we don't do DIPSI.
Don't do DIPSI.
Okay. Priyanku don't do
Our
DIPSI.
medical college in Guwahati, in medical college, DIPSI is a standard.
I think that's the point. This is the most important point. See, what Madam says is a extremely important point for all of us. In medical colleges, there is a difference between the type of patients coming to the medical college and type of patients coming to maybe a clinic at Rohan's South Mumbai clinic. So in that situation, see what happens. The patients are coming from far places, and then you cannot just order HbA1c or sugar test. They won't come again. They will come after maybe 1.5 months or so. So in that case, everybody just give a 75 gram packet of sugar, irrespective of whether they are because they won't come fasting. They come with their tiffins, they come with breakfast, and they will have food. So irrespective of whatever they have taken, you just give them 75 gram of glucose and you just do the screening test. This is ideal test for Indian scenario in the low research setup, or in medical colleges where there are poor patients coming from far places, and there you just do the screening. This is something which is ideal for such situations. But for our the situations where patients are coming, with all these problems, and maybe IVF patients, you just cannot do DIPSI. In fact, that is exactly what Mohan has said. There are two groups, Sheshaya group and Mohan group. Mohan is totally against Sheshaya, and what Mohan says is the limitations of DIPSI are lack of fasting plasma glucose. And this fasting plasma glucose identifies 50% of patients with GDM. So you miss all these patients. Second thing is 1 hour post glucose estimation is important because it strongly correlates with the maternal and neonatal adverse outcomes. So you are missing on that also. And almost all the international groups and associations, they have not accepted DIPSI as a standard test. So this is something which we all should have clear in our mind, that DIPSI is good for Indian scenario where patients are coming from far off and they are, not affording, and there you just don't want to miss them. But if you want to go for an ideal situation is to go for HbA1c and blood sugar fasting post meal, and then only you are able to detect the all the patients of diabetes. And of course GTT, there is no substitute to GTT. So that is what is the take home message of today's discussion.
I think so.
So
What you
DIPSI,
really
yes,
is beautifully is that it's a very good universal screening method. But I
yes,
think
Rohan.
ideal scenario you'd prefer doing your fasting, postprandial, and your HbA.
HbA1c, right. Now these are the reports of Mala. Now we are coming back to Mala. HbA1c is 7, blood sugar 210. So what next? What do you do? This
Fasting
is the
blood
first
sugar.
visit. First visit. Yes. Now what do we do?
Fasting
6 weeks
blood sugar.
pregnancy.
And
Fasting blood sugar. Right.
we will scan her, and then PG2BS, PG1BS, and then risk factor will be explained to the patient.
So I think it's very important that we counsel. As you can see that she's come 15 days post period. Her HbA1c is 7. Her sugars were 210. You can see that the heart rate has also come, but since the sugars are raised, what is the possibility of malformations that we may need to counsel the patient regarding? Like, what is the percentage? Could anyone take the answer on that?
Whenever the HbA1c levels are more than 8.5, the risk goes significantly high. So in these patients, you can give the option of termination versus continuation of pregnancy, because
yes,
now
Nilesh, and her HbA1c is 7.
Yeah, this is 7. So we can continue pregnancy with a sugar control achieved by oral hypoglycemic agents and with or without insulin.
Right.
I think, as Kamini ma'am said also, now with the current development of fetal medicine and all, even a patient with an HbA1c of say 9 or 10 needs to be counseled. But I think termination could be postponed to a point where I think we have good screening techniques where we can find out any anomalies which develop a little later, even by say around 10 to 12 weeks also.
Yeah.
Early NT scan.
Yeah.
Not thinking about termination in this case, at least.
Yeah.
No.
Because we have got plentiful of modalities for diagnosis also, and even the physician and diabetologist going hand in hand now, working with us. So we have got good help from the consultant physicians, consultant endocrinologist, consultant fetal medicine expert. So all of us, all the teamwork can be put in, and we can take this case forward, I think.
That's a
unless and until by about 10 to 12 weeks, if we find something, then is okay. Otherwise, I would like to take this case further.
Right. Now we are taking this case further. And yes, and now what is the treatment? So how do we start the treatment? Now again, Seema, metformin or insulin.
She can continue.
If she is on metformin, but if she is not on metformin, now the question comes.
Yes.
Because this patient has come with the pregnancy, which was unguarded of diabetes. So if she's not on metformin,
Sorry, you speak, please. I thought that I have to speak.
This was the question for you only. Now, if this patient is not for, she's not on metformin, would we like to take this patient on metformin, or we would?
What was her sugar level? What was her sugar and HbA1c?
210.
200.
With 7 HbA1c.
I'll put her on metformin only. And one more thing I'm doing nowadays, if I'm getting this HbA1c more than 6.5 on metformin, I'm adding myo-inositol 1 gram BD, 1 gram OD accordingly. And I'm getting very good response. and insulin would be the last choice for only those patients who are having 300, 400 milligram. And basically those patients are NIDDM or IDDM kind of patients, not frank GDM most of the time.
Yes, but Seema, this is first trimester. We don't want to take any chance. This is first trimester. We want tight sugar control.
It has been stated clearly in all the guidelines that metformin does not cause teratogenicity.
Yes.
And I am using it very safely and frankly.
Yes, Seema, I am not talking.
Metformin causing the
of
abnormality, high blood sugar. I
am not talking of teratogenicity. We are talking of tight sugar control.
Yes.
Strict, that is right, glycemic control should be there, but I was just hearing some few things. I'll never ask for termination or counsel. I do counsel that very high HbA1c and very unstable sugar levels cause anomalies in fetus, but I never give them of aborting the fetus.
Yes, I think there are.
We want tight glycemic control, but I'm not getting your question. What do you want from me?
As anybody from panel
what exactly am I supposed to?
Can I add one point?
Ask me what.
I think we should. This patient is not directly for insulin. I would put her on metformin. I would counsel her on the proper diet, exercise in the morning, early food, dinner, early bedtime, all these lifestyle modifications if she's obese. If she's thin patient and her sugars are high, then maybe we would consider maybe she was a pre-gestational diabetic. In such case, we would have to think of giving her insulin.
Right. Now, how do we monitor this patient? What is?
Not get my question actually.
We do fasting and post lunch for all these patients. Fasting must be less than 92. Post lunch 2 hours must be less than 122.
Okay. Now, so Seema, this what we are discussing is whether to add insulin or to give metformin or to add metformin to insulin. So, as you have said, metformin is the drug of choice.
In which?
Right. And what is the sugar control which we are expecting? With whatever you have started?
So fasting should be less than 100, somewhere around 90 to 100, and PP should be less than 120.
Right. 2 hours postprandial, one less than
120. That is the control we are looking at.
Yes, and 1 hour postprandial less than 140, and HbA1c should be less than 6%. That is what is expected.
Yes.
Now, I would just like to ask you here one point that suppose this patient is having normal sugar in the first trimester, okay? Normal sugar in the first trimester, and she gets the same values in the second trimester, 24 weeks. You do GTD at 24 weeks, and here you find that the sugars are raised. That means she is now GDM. She is not a diabetic. She is GDM. Now, anybody from panel can take this. There is a slight increase in the sugar level. This is second trimester. So the organogenesis is already done. Would you prefer to give her some time for lifestyle modification, as somebody has rightly said, exercise, diet, modification, come back after 1 week, and then maybe we can think of starting treatment? Or do you start immediately treatment, maybe in the form of metformin or insulin, whatever?
I would like to wait in this case for 15 days at least.
I think that is the right answer and right approach. That if the patient has come in the second trimester and her sugars are not so high, then you can definitely think of lifestyle modification as the first line of treatment. And if the levels are high, then again you have to have the treatment ready with you.
I think it's a very good thing that we continue taking the nutritionist also into play, where they're able to give us an idea about the diet which can be followed, because sometimes we may not be the best judges of what foods they need to eat. Sometimes it could be helpful that and as Kamini said, that we have a multidisciplinary approach towards all of it. We may even have to take the opinion of a physician just to be medical legal safe, as your first slide said of the volcano erupting. Irrespective, we still need to take the medical aspect of it and get a consultation done, irrespective whether we're planning medical nutritional therapy or whether we're planning to start insulin or no.
Right. And I think one practical point
I
here.
think
Yes.
can I add one thing?
Yes,
Can
please,
I
please.
add?
Yes.
Yes, because this, if you consider the number of specialists all over the country and in the remote places, you won't be able to get all those nutritionists and all. It is very important that all gynecologists who are looking after patients, they should also have an idea what the basic medical nutrition therapy is meant for and how to advise the patients. That is the standard 1/4 is carbohydrate, 1/4 protein, like that. So simpler way. So you should have the basic knowledge, but once it becomes, it is not responding to your, and of course the first line is MNT, second line is your metformin, and third one insulin. Now insulin, some of us are not very comfortable without a consultation of medicine or an endocrinologist. But with metformin and MNT, I think all gynecologists can handle the case. Ideal situation, yes, you can involve everyone. But otherwise, it is important that we should also learn about this. Thank you so much.
Right, right. Well said, ma'am. And I think one point here, which is of practical importance, there is no substitute to lifestyle modification. There is no question of not going for lifestyle modification. But it is said that if the post-meal sugars are raised, lifestyle is more important, or it works in a better way. If the fasting blood sugar is raised, lifestyle modification may not work. You have to, of course, advise lifestyle modification come what may in all our patients, but in raise fasting blood sugar, this is a practical point which we all should know, that the lifestyle modification may not work, but you have to tell them about modification. So now all is well that ends well. Again, this GDM is controlled properly and the patient delivers at 37 weeks, cesarean section done. I think we'll stop here because we have to already it is 7, so I would like to ask uh, the organizers, shall we go for the third case, or we should, because it is already 7. Dr. Lakshmi, do you want me to continue or shall I stop here?
You can take in a short, Chaitanya.
15 minutes?
हाँ short में ले लो.
Okay, so 15 minutes, we'll just finish this case because it is a long case, but then we'll make it short. This is a case of Shantabai Buzurge. Shantabai Buzurge is a very classical case. I still remember the day when she came to my OPD. She, a 52-year-old lady with edema feet, tense abdomen, with stick in her hand, and flash diagnosis. I thought this is a case of malignant ovarian tumor. The way she was looking at with her ascites and edema feet and stick in her hand, 52 years, she came with her sister. And I thought that it's a case of malignant ovarian tumor. But then when I asked her, she told me that I am pregnant, IVF pregnancy, and my husband is suffering from cancer prostate. So see the zeal with which she is, doing all such things. So the Shantabai ka bhavishya is what somebody has said 30 years back, that you will conceive after menopause. That time IVF was not there, nobody was knowing, but now she has conceived with ER cycle. So embryo recipient, because her husband is already somewhere around 60, he is a case of CA prostate. So this is a very sorry state of affairs, but this is something which is still happening in some of the places, that patients, they come so late with so many problems and still they wish to go for the pregnancy. Her Kundli Yog says that elderly mother, health problems of the partner, and threat to life. So she comes to me at 28 weeks, and she, with her IVF done at some center and recently diagnosed PIH. Till 27 weeks, she was having normal blood pressure, everything was normal. At 27 weeks, she developed PIH. 140/100 was her blood pressure, and she was on Nicardia BD and Labetalol BD. Now, this is the approach. I asked Shantabai, why do you want to go for IVF at this age? She said she did one शेरो शायरी. She said, क्यों डरे जिंदगी में क्या होगा, हर वक्त क्यों सोचे कि बुरा होगा, बढ़ते रहे बस मंजिलों की ओर, हमें कुछ मिले या ना मिले तजुर्बा तो नया होगा. So that is the approach towards life of Shantabai, and I think this is good. But then for IVF, this is not a good approach. So So as per patient's version, she was non-hypertensive, she was non-diabetic till 27 weeks, and at 27 weeks she developed this PIH, and then she was referred to our center for management. Now we go to the into the flashback, and Rohan, I think you should
I think
discuss this.
we know that PIH is developed. I think let's start with discussing the risk factors specific to this case. Sejal ma'am, can you take the risk factors related to this case?
All risk factors are there.
Yeah.
She is hardly able to walk. How can she carry the pregnancy further? That's a
Big question. Yeah.
yeah. So, as her age is the most important factor, and her already the nutritive values of herself to nurture the pregnancy, and so and again the the endometrial level at the time of implantation. So that all factors led to her pregnancy-induced hypertension. That's too very rapidly increasing, and with so much high dose in a 1 week. So labetalol BD and Nicardia BD. So if she crossed the age of viability, I would definitely would like to terminate as early as possible.
I think one point. Yes, Rohan, you can highlight this point.
Yeah, so this was this paper published by ACOG in 2016, which basically gave you the high risk factors, which just showed that what was the risk factor of them developing hypertension or preeclampsia when they've undergone IVF at such a high age.
Yes, even IVF is taken as a risk factor.
Battery of complications she would be expecting. She should be expecting renal failure and
everything.
Even hypertension induced cardiac failure, pulmonary. I mean,
now in the list of
in your OPD.
Yes, actually. So in the list of risk factors for PIH, recently they have added IVF as one of the risk factors, irrespective of age. So IVF is one of the risk factors for PIH.
The Indian
yes, why? Because of increasing donor oocytes demand.
Yes, ma'am.
This is definitely giving a higher risk for the PIH.
There's a Foxy gestosis HDP scoring, which has been published in 2019 itself. Is there available on the website, which basically tells us about all the high risk factors which can lead to PIH. In fact, oocyte donor is considered to be one of the biggest factors. That only that factor that if the patient is 28, healthy, BMI is good, but she has taken a donor oocyte, she has a complete high risk for a preeclampsia.
Hypertension, yes, definitely.
That's something we need to consider. Plus, also all the studies which have been coming out recently, where many of us are moving into frozen embryo transfers, where majority of our cases are frozen embryo transfers. The risk of PIH also increases with that as well. And considering this case was an embryo donor, embryo recipient case, it had to be a frozen embryo transfer, and plus the age, plus other factors, it is going to result in a bad
high risk.
There were other placental complications you should be expecting in this case as well.
Yes. So here comes the role of preeclampsia screening test. We have to, do this preeclampsia screening in this patient. And now this is something which was missed actually in this patient. But I just would like to ask panel whether you give aspirin or heparin combination, or aspirin alone or heparin alone, and what is the dose of aspirin which you prefer?
Depends
I think everybody
on what
can take
exactly the uterine artery RIPI at about 10 weeks it is.
Right.
If the resistance index is very high, I would straight away put her on enoxaparin. I'm not giving any aspirin.
Okay. So considering this is a 52-year-old lady given an embryo donor cycle, wherever she's done it is probably already on ecosprin, already on enoxaparin. So I don't think at this point, even if they had seen her as a high risk at that point, she probably is already on those medications, continuing that as a part of her luteal phase support. So I think she would already be on it. I still think it wouldn't have made that much of a difference to her case, considering age as well as the recipient donor.
We can increase the dose.
Absolutely.
And what is the latest guidelines of aspirin trial? They say that The dose of icosapent is 150.
150.
Yeah, this is something which we all should know. And then there are many trials for heparin as well. Now I am just coming to this point that she is at 28 weeks. She is mild, maybe mild PH, but preeclampsia. But she may get converted anytime into severe preeclampsia, and that is something which we all should know. It's a tough challenge.
We'll do Betnesol cover first.
Yes. I think this is what happens many times, that everything is goody goody and suddenly the patient develops severe preeclampsia and she lands up in a case of severe preeclampsia where you have no choice but to terminate the pregnancy. Now I think we'll not go into the details of this, all the features of severe preeclampsia. We all know this is all theory part, but what is important is of course the management of uh, preeclampsia and severe preeclampsia. And at 28 weeks, if she develops severe preeclampsia, would you terminate her or would you like to prolong her pregnancy for say a week or so? Anybody can take this at 28 weeks. IVF pregnancy 28 weeks, suddenly develops severe preeclampsia. Do you wish to prolong it for, because most of the studies they say that you cannot prolong it for more than 1 week, at the most 5 days to 7 days. So do you want to prolong it or you just want to terminate it as early as possible?
I would definitely take a conservative line with all the investigations done. Give her a betnosol shot.
Yes.
Keep her monitored, and definitely I would take the leverage of 5 days here in this case.
Okay, so in this case 5 days you have some grace period with you. Will you add give Maxel to this patient for neuro?
For neuro,
Yes.
the minute you
Yes,
give Maxelf,
definitely
you
yes.
deliver after 24 hours after giving Maxelf.
Right. So neuroprotection with Maxelf is also something which is important. So steroids and Maxelf both together will work in this patient, and she will definitely sail through. Maybe 1 week we have some time, and then she'll ultimately will get babies around say 1.2 1 kg, which is good enough for us. I think the last point which I would like to ask you all here is, how old is too old? And I want opinion of everybody in the panel. How old is too old? Because this is something which is not acceptable. You are doing embryo transfer in a case, in a lady who is 52 years with her husband taking treatment for CA prostate just because she wants baby. Will you take this patient for IVF? How old is too old?
They actually, I would like to say something. There is, we cannot, actually, we cannot demarcate the cutoff, but still, for the adoption, the legal limit for, like in Western countries, for the couples combined age should be below 90 years.
That's in
So
India.
that if we consider approximately female age should be below 45.
I think that's
So Sejal, you take 45 as cutoff. Dr. Kamini?
No, ideally it should be. I don't think, but ideally it should be.
Yes.
Well,
Kamini.
if she's medically fit and if the physician gives the fitness for obstetrics, if she does not have any comorbidity, like even she can conceive by 47, 48 also. But the fitness is definitely required.
Pregnancy itself can cause many other add-on the other health issue later on also. So even pre-pregnancy fitness cannot predict that definitely she is gonna have a good outcome.
Nilesh, what is your take?
Pandora's box.
I think, sir.
I know.
That is
I think
mandatory
this is
to
a
have a preconceptional fitness, but that doesn't predict or doesn't give any assurance about her future good outcome.
But I agree on 90 years combined age.
90 combined. Okay.
Yeah.
Nilesh, what do you say?
I think, sir, more than 50 definitely no. 45 to 50 will be a gray zone where we have to take a decision depending upon the comorbidities present or absent.
Okay. Dr. Lakshmi?
I will go with Nilesh and Ritu. Ideally, 45 is the ideal cutoff, but we all take patients up to the 50 years of age, depending on the presence of comorbidities. And as Sejal has said, you can never predict, even if you are having physician fitness, I mean, anytime things can go haywire.
Yes.
Ritu, are you there? Ritu? So we have final say by our expert, Dr.
Yes.
Seema Pandey. Seema, and of course, Dr. Sneha is also with us. Dr. Sneha Muyar and Dr. Seema Pandey.
Yes, Chaitanya.
Madam, please unmute yourself, Seema madam.
Seema, unmute yourself.
Seema ma'am, you're muted.
We should ask the obstetricians how they are managing the pregnancies. We all.
For me also beyond 50, I completely know if I know the exact age. 45 to 50, it depends on their need plus her physical fitness, how fit is she, and how are the things. And yeah, 45 till 45, if everything is fine, 40 is new 35, no? So accordingly, we are switching over till 50 for things. Yes.
Dr. Sasikala, Dr. Sneha, madam, you just give your opinion.
Yes, yes. Chaitanya, just to share with you an interesting fact, I think we have had enough discussion. 45 to 40 to 45 is the most acceptable age group, I suppose, and 45 plus definitely you have a very high risk. Of course, if it is associated with comorbidity. Just to share with you, if you remember, few years back when Dr. Milind Shah was the national president of ISOPA, I had a debate. I had presented a debate in Pune. And I was given a topic of pregnancy after 60s. I have gone through all the details on net. Surprisingly, the complication rate was not very high. But, if you allow me to say that, in fact, we are so conservative that, I was not ready to accept the topic because I didn't want to be in favor of, the pregnancy with the advanced age. So that horrified we are with the age and the associated risk factors. But as far as the scientific fact goes, and our practical experience also, after 40 years, definitely, if it is associated with comorbidities, we are definitely at a higher risk.
I think, as if I may add one point, it's not only the question of what problems we face as obstetricians during pregnancy and you IVF people during giving IVF. We have to also think of how the baby, how the mother, how long she's going to survive after having a baby at around 50.
Exactly. See, that one of the that is what one of the point of debate was that how she's going to rear this baby, how she's going to develop this baby, and how they're going to parent this baby. So these are all the, of course,
Discussions which are to be which are to come later on. But during pregnancy, definitely the mother as well as the baby both have to
But
suffer.
we also have a social responsibility. So we have to counsel the patient on all these things before we take up the case.
Absolutely.
Right. So I think now the final word by Modi.
Yes.
You can see here what Modi government wants or what Modi wants. Modi wants 50-year age limit of women for taking for IVF. So Modi says 50. Modi hai to mumkin hai. We all agree with Modi and we consider 50 as the age limit for IVF. So I think I, along with my co-moderator, Dr. Rohan Pashetkar, I thank you all, wonderful panelists and wonderful audience. It was really a great experience. Thank you, Dr. Lakshmi, for giving us this opportunity, and thank you all panelists for giving your inputs, which are so valuable. Thank you so much.
Thank you, Dr. Chaitanya, and thank you, Rohan, Seema, and all the co-panelists. Lakshmi, thank you very much. Dr. Chaitanya, there is somebody to see you. Come. Hi,
yes.
sir.
Hi,
Good evening. I'm speaking for the first time in person, even on virtual platform. So I have said hello.
Hi, sir.
Thank you, ISOPERB, Lakshmi, Chaitanya, and Rohan, and all my panelists. Thank you so much. It was a wonderful discussion, and I really enjoyed it.
Thank you so much, Lakshmi ma'am.
And thank you for this.
Chaitanya is an excellent.
Yes, I must
and so does Rohan.
Thank you, madam. Thank you.
Thank you, everybody. Bye.
I'm so
It was a
happy
very
that our
interesting
guest
panel.
of